All right, ladies and gentlemen, we're going to get started here in a moment. If you could please find your seats. Thank you. All righty. Just a few housekeeping items for those of you in the room. Restrooms are in the back, men to the left, women to the right as you go to the back. Please silence or turn off your phones and mobile devices. Good morning, everybody. I'm Craig Shriver, professor of surgery here at Uniformed Services University and director of the Mertha Cancer Center and Research Program. I'd like to recognize in the audience President Richard Thomas, President of Uniformed Service University. Sir, thank you for your great support of this event and the life of Dr. McLeod. And I'm also thrilled to introduce dignitary, the next Dean of the School of Medicine of the Uniformed Services University, Eric Elster. Congratulations, Eric. On behalf of President Richard Thomas of Uniformed Services University, the Mertha Cancer Center Research Program, and the Center for Prostate Disease Research, welcome to the McLeod family, friends, and loved ones in attendance here today at USU's Rice Hall. Mrs. Claudia McLeod, Lieutenant Colonel David McLeod Jr., Ms. Lisa Wild, Mr. Kevin McLeod, Ms. Yvette Saylor, Ms. Ann Saylor, Mr. Jimmy Gerhardt. Thank you all for being here. Later in the day, we will also be privileged to have in attendance for this afternoon's events additional dignitaries who will introduce at the time. Welcome to all of you watching the live stream on the university's YouTube channel. Our sequence of events throughout the day are as follows. From 9 a.m. to noon Eastern will be scientific presentations and personal recollections of working with Dr. McLeod from co-authors of 12 of his most impactful scientific communications. At 1 p.m. Eastern, we will have a celebration of life ceremony with various distinguished speakers. Then at 2:30 p.m., we will have open tributes consisting of brief 5-minute stories or recollections from 24 friends of Dr. McLeod. I'm also pleased to announce that 3 weeks ago on February 24th, the USU Names and Honors Committee endorsed and USU President Richard Thomas approved the creation of a named position within the CPDR of, quote, the Colonel David G. McLeod Translational Research Scientist for the USU Center for Prostate Disease Research. Thank you to the senior leadership at USU and specifically to President Thomas for recognizing Dr. McLeod in this extraordinary fashion. And now to get us started, I am pleased to introduce the MC for this morning's scientific session, the director of the Center for Prostate Disease Research, Commander Greg Chestnut. Greg?
Good morning and welcome, everyone. It's my privilege to introduce our speakers for this symposium this morning. Though each speaker is a long-term friend of CPDR and colleague of Dr. McLoud, needs no introduction. I'll start with Dr. Judd Ball, who's coming from Duke University.
Thank you very much. It's a true honor and pleasure to be here, and I'm just so thrilled to be here to help honor Colonel McLeod. So I do bring greetings and condolences from Duke University. Dr. McLeod was extremely supportive of me getting affiliated with Duke years ago and to be able to do my fellowship there. Oh, let's see, can we get back to the, okay. So my goals for this brief talk is to honor the chief. Dr. McLeod, contributed immensely, and I can't even describe in words how much he has done for military medicine. But for me personally, seeing his team building, his support of trainees, motivation, passion, and commitment. I want to briefly discuss some of the publications that we did related to prostate cancer in African American men, his historical significance in relation to the early years of CPDR, and the impact on my own career. So I found this slide. This is a historical intro slide. Back in the day, on presentations that we did, we always use this title slide. It shows the original Walter Reed, and that was Dr. McLeod's beloved institution, and here obviously at Uniformed Services University. This is a picture that I've had on my desk and in my office since 1986. And this was the Kimbrough meeting in 1986, and I was very blessed to receive a research award. And this is Dr. McLeod and I. I put this out on Twitter recently, to start to, try to promote this event. And I got a lot of abuse about the mustache, but this is, so I put this slide in to, illustrate, lifelong partnership. Dr. and Mrs. McLeod. This was actually in 1992. We were in Orlando, Florida at a medical meeting, and this on Halloween. And this is, Dr. McLeod is the horse. I'm not sure, I can't remember what was this? You were a damsel in distress, or I think, but just to recognize how amazingly supportive Claudia was. And I can remember many times throughout our residency and early years where I don't remember the science, I don't remember much about urology, but I remember some of the social events and how warm you were and how much that meant to us, as residents and trainees, as far as, being a team building, essentially. Now, I also want to recognize the most important person, my wife, Ellen. She's here in the audience. And so we're going to be celebrating our 40th wedding anniversary later this year. And Dr. and Mrs. McLeod have pretty much been in our lives for the whole time, almost the whole time. So this is a picture that was taken in April of 2018 at Shiv's daughter's wedding. And, Dr. McLeod was being his usual self. And, I love this picture. I also want to recognize Dr. Rich, Norm Rich, who was the chair of surgery for many years. This is a photograph taken a couple years ago, and it's the last picture that I had of Dr. Rich and Dr. McLeod together. And I just, looking back on it, it was really an amazing time seeing these two giants of military medicine work together and be so supportive of the young people and the group building CPDR. And they were great leaders in that they let their teams, blossom, and we're certainly not micromanagers. And I just want to recognize how much that meant to me and to all of us. And then I also want to recognize Dr. Shrivastava, Dr. Petrovics, and Dr. Doby. Dr. Doby is in the audience and did a great service in helping to organize this event. Shiv was with our program right from the beginning and worked with Dr. McLeod and I for, the first 12 years that I served with CPDR, and then with Dr. McLeod until recently. So this was also a picture that I'm really proud of that was taken at Shiv's daughter's wedding, and this was the last time that we were all together. I also want to recognize Senator Stevens and Senator Dole. This was a picture taken April 10th, 1992 at Walter Reed, and this was for the Us Two support group. And you know, at the time I was a young guy, and I don't think you recognize the gravity of some of these opportunities until you look back on this, 25, 30 years later. But my goodness, we had some of the most powerful people in the world that we were responsible for, that we had the opportunity to care for. And that's the other thing I want to recognize about Dr. McLeod is that, he was willing to share these people in the sense that, sometimes a leader would, if you will, hog the VIPs and not really want to let the young people be involved. That was not Dr. McLeod. He was very, very open to allowing all his people to be, have an opportunity. And this was taken at Walter Reed, but we had another opportunity where we had a support group down at the US Capitol. Now, I want to just get into the science. I did a PubMed search in preparation for this talk, and I was amazed and really humbled. We published 100 papers together, Dr. McLeod and I, starting in 1986 all the way until 2018. And I remember the first and last, you remember more than just about anything. The first paper we published was on the AMS 600 or 800 penile prosthesis. And I'm just going to digress for a minute. Remember when we got to go to Minneapolis? After we published that paper, we went to Claudia and Dave and Ellen and I got a chance to go to the factory in Minneapolis. I remember riding in the limo, and for some reason I remember at that time Dr. McLeod had some kind of business deal, and I can't remember what it was, but it made an influence on me that to try to recognize, hey, urology is really important, but you have to take care of yourselves. And I learned a lot about investment just on some of his interactions. And then the last paper was in 2018. We had a chance to work together on a project looking at the history of anti-androgens in prostate cancer. And that meant a lot to me because in 2017, we were working on this paper, and I got to interact with him a lot, on the phone, and just have that chance to deal with him scientifically again, and it was really special. Dr. McLeod made a tremendous impact on our field. This is from PubMed just a couple days ago. Over 15,000 citations. His H index was very high in regards to his impact scientifically. And this is a list of his 15 top cited publications. Dr. Crawford is going to speak a little bit later, but the number one was his work with flutamide, which was an early anti-androgen used in prostate cancer, and that ended up being his most impactful publication. And this just shows the journals that he published in. The green is the Journal of Urology, and I just want to use this opportunity to recognize how supportive the AUA has been to CPDR and to our careers, and his greatest number of publications, I think 57 is from the Journal of Urology. Now, I just want to switch gears and just talk very, very briefly about the work in prostate cancer in African American men. This was an interest to CPDR right from the get-go, and this slide shows the issue that we faced with prostate cancer in African American men being more common, more lethal, and over the last 30 years trying to figure out the causes of this, and it's clearly multifactorial. We had an interest in looking at this issue in the military population because of its equal access nature and the fact that during this era, the military healthcare system was huge, a lot of patients, a lot of patient care. It was in the golden era, I would say, and this was our first publication showing that African American men had higher PSA levels. And thanks to work that we did with Dr. Sesterhan, who's going to speak a little bit later, but through her work and Dr. Mistophi's work with these carefully step sections prostatectomy specimens, we were able to measure exact tumor volumes. And the key message from that paper was that controlling for everything that we could think of, including exact tumor volume, African American men still had higher PSA levels. And so that was in 1995. And this just is a graph from that paper showing that the PSA levels were higher even down to the careful tumor volume assessment. This paper had 217 citations over the years, and was certainly one of the papers that is still cited when review articles are written about prostate cancer in African American men. That was followed in 1996 by our paper in the New England Journal of Medicine, and this really got early traction for CPDR in the national spotlight. It was really the first study to propose PSA screening guidelines specifically to optimize early detection of prostate cancer in African American men. This received a lot of media attention, amazing amount of media attention. And for the most part, I would say 99% of it was very positive attention, just focusing on that we needed to do a better job of screening African American men for prostate cancer. I'm not going to go into the weeds with the technical details, but suffice it to say, we also collaborated with the Mayo Clinic. They had published some papers on predominantly Caucasian populations, and even comparing our results in African American men to Olmsted County in Minnesota, that we found that the African American men had higher PSAs. We took a reverse stance in that up until that time, the screening guidelines had used the 95th percentile of PSA in the normal controls. This paper was the first to use the 5th percentile of PSA in the patients to come up with reference ranges. And this was the bottom line take-home message of the paper. These reference ranges stratified by age and ethnicity, optimizing when patients should be referred to urology or have a biopsy for prostate cancer. And as I said earlier, this received a lot of attention. This was a headline from USA Today. We were very blessed to be interviewed on ABC, CNN. It probably had coverage in hundreds of newspapers. And I know it kept the public affairs office at Walter Reed pretty busy for a couple of days. And it was referenced in various review articles. This was just one example. And although we did get some criticism, some people said that because prostate cancer was more prevalent in African American men, and we should have wanted to do a better job of detecting as much as possible. Some people criticized the reference ranges, saying that we shouldn't have picked higher values in African American men, but the data seemed to support this, and I think the criticism was much less than the people who thought it was a good idea. And then it was in the AUA best practice guidelines for many years as far as recommendations. I just want to mention a couple of follow-up papers that were important that may not have gotten the attention. This was a paper that we did with the Army-Navy Serum Repository, looking at what the PSA levels were in very, very young men. And we also showed that African American men, even as young as 20, had higher PSAs. That was by Dave Preston, one of our residents at Walter Reed, who did a very nice job. The paper in general brought a lot of attention just to fine-tuning screening. And so there was a lot of dialogue that came out of this. What's the proper age to initiate screening? What are the proper screening intervals? What are the best PSA guidelines? And it was recognized in the Washington Post as well. This was just one example where our work was referenced this was one seeking a cure for what's killing Black men. And this paper also was cited 317 times. And then another paper that I'm just going to briefly mention that came out around that time in 1996, which got quite a bit of attention. This is looking at ethnicity and outcomes after radical prostatectomy. And this was somewhat controversial at the time because we showed that even in the equal access system, trying to control for pretty much everything we could control for at the time, that the African-American men seemed to have a worse outcome after radical prostatectomy. Now, subsequent papers have not been able to find this, but this certainly started a dialogue and I think increased the awareness and trying to do a better job of detecting prostate cancer in African-American men. And this was cited 143 times over the years. And then just to, very, very briefly, this led to some really nice studies on this was a paper that John Bauer, one of our residents, did working with Dr. Sesterhan, working with the folks at Georgetown on one very early 3D modeling to try to determine the best way to biopsy a prostate. And the key teaching point that came out of this was laterally directed biopsies. Again, in our whole mount series, we found that the prostate, many of these early prostate cancers were focused more laterally down towards the mid and apex. And so this was one of, I think, a very important paper from that era. Then finally, we developed the CPDR Parton tables. Now, those who do work in the field of prostate cancer, the Parton tables were developed at Johns Hopkins. And this was a follow-up to that done by Kevin Genzarchek, one of our urology residents, of a similar table. But here we were looking at number of biopsy cores positive. But again, just an example of some of the papers that came out during that era. I'm going to end with this slide. This is Foursquare, and I was talking to Claudia and Yvette, and just before this began. Foursquare is Dr. McLeod's beach house at Oak Island, and this was a picture I took on December 18th. I had received a message from David Jr. that morning that Dr. McLeod had passed away, and we just happened to be down at the beach. We have a place about 2 miles away. And so I went there, and Ellen and I went on the beach, and we said a prayer, and I bawled like a baby. And I want to just say one thing. I was trying to find a picture of the original Foursquare that when I was a resident, 86, I believe, Dr. McLeod invited Ellen and I to go down and stay at the beach house. And what an amazing act of kindness, and what an impactful thing that had on a young person. And so that turned us on to Oak Island. And a year later, when my mom passed away, and I inherited $25,000. And immediately went and plopped it into a beach house at Oak Island, or we plopped it into a beach house. And so we've had that association down there since 1987 when I was a chief resident. And so I just wanted to show this slide. I want to thank Colonel Craig Shriver very much for organizing this, the USIS team, the CPDR team, and I want to thank David McLeod Jr., Claudia McLeod, and the McLeod family. Thank you very much.
Thank you, Dr. Mull. Our next presenter is Dr. Nancy Dawson. Dr. Dawson, after her career at Walter Reed, is now a medical oncologist and the William Scholl Professor of Medicine and Oncology at Georgetown. Dr. Dawson.
Good morning, everyone. It's nice to be here. Really happy that I was a part of this tribute to Dr. McLeod. I am Dr. McLeod's other child. Judd is we used to joke about that, the kids, you know, and I was the quieter one. So it's always good to come after Judd because I don't really have a lot to say, and he always goes over. But that's okay because I don't have that much to say. So Dr. McLeod and I had a different relationship because, unlike with his son, because I think for those of you who don't realize this, there is a difference between males and females. And I was the I've always sort of joked about saying I'm the girl who does prostate cancer. Everybody knows who I am because there aren't very many women who specialize in prostate cancer. In fact, as an oncologist, I was the first woman in the United States to specialize in prostate cancer. So we had a very different relationship because that's just the way it is. And we did write a couple of, we were on a couple of papers together, and this is just a case report. But it was an interesting case report and one which had a lot of significance to it in how we manage men with prostate cancer. So we've been talking a lot, Jed's been talking a lot about PSA, and we use PSA as sort of a marker of how your cancer's doing. So PSA up, you always say PSA up is bad, PSA down is good. And so that's sort of the way to look at it. And this was just a case report of a gentleman who had prostate cancer, and he had a dramatic drop in his PSA and a dramatic rise in his PSA relative to taking a drug known as Megace. And Megace is used as an appetite stimulant. So a lot of people get it to try to have them gain weight. People haven't really thought of it as a treatment for prostate cancer, but it can be. And what's interesting about it is sometimes it can make people worse, and sometimes it can make people better. And we really don't know why, and we don't know who those people are. So this was just a case of something that I thought was interesting, and Dr. McLeod said, yeah, we should write that up. So we did. So this is a gentleman. He was a 71-year-old male, diagnosed with prostate cancer in 1981. You know how long ago this was. He had poorly differentiated prostate cancer. He had his prostate taken out, and he had a positive lymph node, meaning his cancer is probably going to come back. In 1985, his cancer did spread, went to some lymph nodes. It continued to spread. He had his testicles removed, which is something that we do to, prostate cancer stimulated by androgen. So that's a therapy for it. But in 1991, his cancer got worse. It was in his bones, it was in some soft tissue, and he got started on Megace. Now, I can't actually remember why I started him on the Megace. Probably doing it for his appetite. He was probably losing weight. That or I didn't know what else to do, because back when I was first specializing in prostate cancer, basically you took their testicles off. They didn't even have the drug called Lupron, which everybody gets now. And when that didn't work, you gave them prednisone, and that was it. So a lot has happened. So I gave him Megace for some reason, and his PSA started to go up. And I stopped his Megace. I started him on a drug called ketoconazole, which is an antifungal drug that we also actually works, but people didn't really realize that. And then he had some side effects, so I stopped that, and I put him back on his Megace. And his PSA started to go up. So I stopped his Megace, and the PSA went down. And I'll show you now the graph of what that looks like. So this is just over time what his PSA was doing. And his PSA was going up after I started his Megace. So at point A is where I stopped the Megace, and his PSA goes down a little bit. But I also at that time started him on ketoconazole. So then his PSA went up. So I stopped the ketoconazole, all right? And the PSA went down. I thought, okay, this is strange. All right, so then I restarted the Megace, and his PSA went back up. And then I just stopped the Megace, and it went down to almost nothing. And that's all I did. And so why is that interesting? Well, it's interesting because we didn't know why this was going on. I think we still don't. I would love to ask Jed if he can explain to me what's going on here. Nobody really knows why this happens. They've talked about this thing called the anti-androgen withdrawal syndrome, where you take something away and the person gets better. And they used to think, and there's lots of papers which he didn't share with us about mutations in the androgen receptor. And then they decided it was probably just oversensitivity to low levels of androgen. And now I've decided I really don't know. So in 1995, what we concluded is that this sort of broadened what we called the anti-androgen withdrawal phenomena. And it emphasized that a man, if you're stopping something, you need to assess whether that had an impact just as much as if you're starting something. So that's very important, because if you start something new right away and the person gets better, you don't know it's because of what you did or what you stopped. And we didn't know why. Could only guess why this was happening. So in 2021, I would tell you that since that time, I've actually given people Megace. There was another gentleman I treated, a senator, who I gave Megace to, went on to win his 6th term as a senator, must have been the Megace. But his PSA dramatically dropped. He got a lot better on Megace, gained a lot of weight, and did well. And so I went on to do a large trial in the CALGB, now the Alliance, men with castrate-resistant prostate cancer, and they got Megace, 2 different doses. And the trial wasn't a positive trial, but there was one thing that was very interesting. There were the 7% of men who got much worse when they got Megace. They had a flare. Now, some people got better, but 7% got much worse, which I think is the same group that have that ARV7 mutation, which is something that was discovered recently that tells you that androgen really isn't feeding this cancer. So it's an interesting phenomena, and I don't know what's going on, but I know Judd can figure it out, and he's still got a few years, you know. So this is my personal thank you to Dr. McLeod. So I met him when I was a medical student. I graduated from medical school. Oh, that's not 1998. Oh, I was no, 1978. Little typo, it's late at night. So in 1978, I was a 4th-year medical student. I had one of those scholarships. I was a health professional scholarship program student. I was going to Georgetown, which at the time was the most expensive medical school in the country. And I rotated at Walter Reed in urology. And that was when it was located, you know, on some back stairway way upstairs. And that's the first time I met him. He was very quiet back then, at least towards me. You know, he never made those jokes in front of me. So, but he was always very supportive of me. And I could always go in and ask his advice. And he was always very willing to help me and give me his opinion. Actually, he used to compliment me, you know, saying ridiculous things like I was smarter than he was. But what thing that he did for me that most people would not know, there's a lot of things you just don't talk about, is when the breast cancer money came around when the Department of Defense suddenly got all this money, the Army got all this money to do breast cancer research. And most people don't know much about that whole episode, but there was a large chunk of money that involved fetal research. And so they decided they weren't going to spend it on that. And they called John Redman, former chief of oncology at Walter Reed, and said, guess what? We're giving you, and I forget how many millions of dollars it was, to do research in breast cancer. And we expect you to, you know, figure out what to do with this and have a nice day. And so they were trying to figure out how to spearhead this. And someone thought, since I guess at the time I was lieutenant colonel, I retired as a colonel, but and I was female and I was an oncologist, so I would be ideal to head up the breast cancer funds. Unfortunately, or fortunately, I didn't want to do that. I mean, my area is prostate cancer. That's what I loved, you know. And so I was sitting in oncology, it was, you know, Friday afternoon or whatever. I think it was a Friday around 5 or 6, when Dave calls me and says, we got a problem. He says, so-and-so is transferring you to the R&D command, you know, as we speak. And you don't know anything about this. And I don't think that's going to be good for you, and it's certainly not going to be good for me. And here's who you have to call, and you got to do it now. And I did, and that was it. I wasn't going to R&D, and I wasn't heading up the DoD breast cancer funds. And as I said, the rest is history, and I want to thank him for that. That's all I have to say. Oh, one other thing. Most people don't know what this is. This is a reprint. Now, you see these. Everybody's got the internet, and everybody takes articles off the internet. Back when we were doing this, you would get a big box of reprints. And this, my paper it was only 2 sides. You know, this was a really, really long paper. You know, but this is, I actually have my original, you know, 5 reprints. Thank you.
Thank you, Dr. Dawson. Our next presenter is Dr. Inga Rosner. She recently retired as CPDR director and is currently the Shar Chair for Urologic Oncology at Inova Fairfax. Dr. Rosner.
Good morning, everyone. It's really a pleasure to be here, but we're sad that we're here for this reason today. And I just want to extend my condolences to all of you. Dr. McLeod, it's sort of, I still feel like he's with us because the family of residents, you know, it's just nice to come in here, and I'm hugging people probably inappropriately, but I think his legacy is really the people he trained, and his work ethic. We feel that every day. I have conversations where I am now. I work with Ed Paquette, who was a resident who trained under Dr. McLeod as well. And just the inability to leave work when the work is done, because there's always potential work there. Bennett Stackhouse just said that this morning. So I think all of us sort of feel the same, and that there's always people to take care of. And he always, always put the patients first. And so for me, that's the biggest legacy that I carry with me today is I'm thankful that I can take good care of people thanks to him. And I always try and put the patient first. So I'm now at ANOVA, which is a lovely place to be. And I get to work with another prior Army resident, Ed Paquette, as I talked about. But my time at CPDR will always be with me. So I was asked to review this article that we did together. Steve Bursell was the lead author, and this is in 2005. Steve Bursell was a wonderful colleague. He was the associate director for CPDR for approximately 5 to 6 years after Dr. Mal had left, and that was then followed by myself and then by Kevin Rice. So I want to say thank you to Steve for collaborating on this paper with me. And ironically, it was an update on imaging for prostate cancer. And Dr. McLeod always embraced technology and always wanted the in thing. Walter Reed had to have what was, you know, cutting edge. And when I think about robotics, although he didn't necessarily embrace the robotics, and there might have been like a little bit of pull between the patients getting an open RRP versus a robotic case, but I think he was very supportive of Dr. Shankman and bringing on robotics to Walter Reed. I think very, very early on, we were, I think, the first DoD facility to have a Da Vinci system. But that was, again, him. He wanted what was in, what was new, what was best for the patients. And this article came up because I think it was Thomas Keene, who was down from University of South Carolina, had come up to give a lecture or do, you know, visiting professor. And we were up on the 7th floor for a nuclear medicine imaging conference where we used to review the PEDS cases, but also prostatant scans, which Dr. McLeod loved. And he really believed that we could do better in terms of staging, diagnostics, counseling our patients, and that would be with biomarkers or figuring out, you know, who really has aggressive disease versus who has more indolent disease, and imaging. So he always embraced the technology. And this was just a review article in 2005 on MR and Prostate and PET imaging. And it has exploded. This is just a picture of myself and Dr. McLeod, and all the residents know this was like a big thing. You'd go out in front of the old Walter Reed, and when you were a chief resident, you were graduating, it was a big moment to have the resident program picture, and you got to stand on one side of Dr. McLeod, and the picture was taken. So this is my chief resident year. I graduated with Dave Osborne and Dr. McLeod. There's Dave Boss in this corner. He's here today. And then this is Steve Bursell, myself. There's Chad Tarosa, who was another resident, and then obviously Dr. McLeod. And I have this picture up in my office today. So I just did a PubMed research on 2005 versus 2020, and the articles about prostate MR and then Prostate and PET imaging. It's incredible how much it has exploded. And I think Dr. McLeod would be so happy and proud that we were always sort of learning and using the latest technology, especially MRI. So in 2005, there were 174 publications on prostate MRI. Now there's over 1,300 in 2020. And prostate MR is really, I think, standard of care now prior to a biopsy. Prostate has gone by the wayside only because there's greater imaging capabilities and nucleotides. So in 2005, 8 publications, and in 2020, 714. And I suspect this area of PET imaging with prostate cancer will continue to grow. And again, to the MRI, this is just another enormous thank you to Dr. McLeod, always trying to embrace the best things or technology for patients. When I left the NIH, where I did my fellowship, which was sort of the nexus for prostate MRI with Peter Choike, Peter Pinto, Baris Turpke, I came back and I was like, I think we really need to sort of invest in doing MRI targeted biopsies. Dr. McLeod was on it. You know, once he got a bee in his bonnet, he made things happen. And when I took over, the energy to try to complete anything in the DoD or at Walter Reed took so much energy, but somehow Dr. McLeod, by the grace of God, always got things done. And I think within 6 months, we had this system. This is the UroNav. This is actually in the urology clinic, or the former urology clinic, because it's under renovation. But this is the UroNav system. This is a prostate MR. And we started doing prostate MRI targeted biopsies in 2013. Again, the first hospital in the DoD system to do this. Where I just started at Inova, they just started doing MRI targeted biopsies 2 years ago. And we did this in 2013. And that was Dr. McLeod. He just made things happen, and he was relentless. And I'm so thankful. And our patients have benefited from his efforts. And then this is just the current state of PET imaging. Again, an enormous field in medicine that is exploding. And it's all about helping our patients in terms of diagnostic capabilities, staging, recurrence. Prostate is sort of now gone by the wayside, as I've said, but here's PSMA PET, which is similar. A prostate scan was a monoclonal antibody targeted against the PMSA, and now there's just a different agent. But this is from the 2021 guidelines, obviously updated, but this is just from yesterday. I just took this. So I know that Dr. McLeod, you know, would be a tour de force and would want to get any of these remaining technologies at Walter Reed. So I just want to say thank you. Thank you for allowing me to speak today. And Dr. McLeod will always be missed, but he's with all the folks that he ever trained.
Thank you, Dr. Rosner. Our next presenter is Dr. Isabel Sesterhan. Dr. Sesterhan is the Chief of Genitourinary Pathology at the Joint Pathology Center. Dr. Sesterhan.
I appreciate that you invited me to talk about Dr. McLeod. You will not hear a lot of medicine here, but more or less my personal interactions with Dr. McLeod. There are two people here on the screen. To the left, you see Dr. McLeod, and to the right, you see Dr. Mustofi. Dr. Mustofi was the first uropathologist in the world, and I believe still is the one. So both of them knew exactly that each subspecialty, urology could not live without pathology, and pathology could not live with a close connection to the clinician, to the urologist. And this is how the interaction between the two men started. So Dr. Mustofi went one time to Walter Reed for a physical, and a young person told him, young resident told him, you have impalpable nodules, so we have to take biopsies. So Dr. Mustofi got biopsies done at Walter Reed, and he brought the specimens back to the AFIP. We processed it, and he got the biopsies before Colonel Davis and I could look at it. So he had carcinoma, and it was decided he would be operated at Walter Reed. And the surgeon was Dr. Pat Walsh, and Dr. McLeod was his assistant. There was somebody else, I don't remember. And I saw Dr. McLeod taking care of Dr. Mustofi post-operatively. That was the first time I saw him. And then I didn't hear of him. You know, we didn't work together but I met him at the AUA meetings. He always had a nice word for me. We said hello. And then it so happened that there was a meeting in Bethesda of urologists. There was a urology meeting in Bethesda. Dr. Mustafi was there, I was there. And we went to lunch. And on the way to the lunch place, Ian Thompson came. And Ian Thompson said, "Oh, I heard that you got $3.5 million. Dr. McLeod got $3.5 million. Did you know about it?" And I said, "No." So I went to Dr. Mustafi and I said, "Did you know about this?" He said, "Oh, Dr. McLeod got $3.5 million. So he just became very slow in his walk and joined Dr. McLeod. And that is history. The two of them decided that this money should be used to build a research facility. And this is how the CBDR started. Now, we had at the AFIP, Dr. Mustafi had experience in cutting prostates for as whole mount sections. And we worked with a radiologist from San Francisco and with the Navy Hospital in San Diego to help this radiologist find out if he on MRI could actually see extraprostatic extension. So the discussion was about the thickness of the sections we should take. So we decided the sections can't be more than 2.2 millimeter intervals. So the radiologist could determine really, am I right or wrong when I look at these MRIs. And to get 2.2 millimeter sections of a prostate in regular intervals, we got the finest meat slicer in a delicatessen store. So all these prostates were sections with a meat slicer. They were thin, they were flat, they were hand embedded and hand cut. And we found out that Dr. Matre was correct, that he could find extraprostatic extension on the MRIs. So, and when Dr. Mustafi and Dr. McLeod got together to start the CBDR, we said immediately we will do the whole mounts. We cut them all the same way. And so this was the beginning of the cooperation. So we worked with CBDR in close association, and when we had enough images, enough cases studied, we had a resident, and this was Dr. Bauer. Dr. Inga Rosner spoke about his, or Dr. Maul talked about the 3D reconstructions of the prostates we did. Can we go ahead? So the beginning of the CBDR, I forgot, is here. You have the entire CBDR team. You have Dr. McLeod, Dr. Maul, Dr. Srivastava, and his co-worker. In the front, you see Dr. Bauer, who made the 3D reconstructions, which were tactile. So he could learn how to biopsy. And he told me once, a mistake he made when he took biopsies, that he put the needle into the prostate and then shot the gun. And then he overshot the tumors. So he learned to have to pull back, touch the prostate very carefully with the needle, and then shoot. So he had good results. And then came the most important time for me, when Dr. Doby and Dr. Petrovic developed an antibody to the ERG oncoprotein. And they had different clones apparently, and they needed to know which one of those clones they created would be actually visible in histology. So we took one of those whole mount, we took a whole mount section, or several, and tested every one of those antibodies. And we found one which was for me just unbelievable, which stained only tumor cells and endothelial cells. So it stained nothing else. So with this, we had the ERG oncoprotein in our hormone sections. And we found immediately, if you take a hormone, stain it, that many of those tumors have two separate tumors, which are also genetically different. And you see also that that you can get tiny foci, which show the ERG oncoprotein expression. And you can tailor the therapy, I guess, accordingly. And there was a review paper by Dr. Rosen, Marcel, McLeod, Dr. Srivastava, and Dr. Dobi on the potential of the ERG oncoprotein in prostate cancer treatment. And you see here that the ERG positive tumors may represent one of the largest molecular subtypes in prostate for targeted prostate cancer therapy. And you see that papers talking about the importance of the ERG increased from 1 to over 1,300 case publications up to date. Here you have two prostates in Caucasian men and African men. You see the Caucasian patient has I can't do this here. He has a large focus of positive carcinoma, and he has a tiny one without ERG expression. And you see the vice versa in the African Americans. Many of those tumors in the African Americans will not have the ERG oncoprotein. Only here in fine, small focus is possible. And this antibody was distributed through the entire world. You see all the places where the ERG antibody derived from from the CBDR is utilized. Then the section, the hormone sections we can create with the 2.2 millimeter intervals have been also used to try MRI imaging. And here is one of those cases which we sliced post-surgically and which are fixed and gave it to a radiologist. And they told me, you can see that with a 7 Tesla MRI, you can see, what do you call it here? I do something wrong. You can see that there are tiny nodules in this prostate, which are visible on imaging. You see the architecture of this prostate slice. And you see this little nodule has a histologically completely different appearance than the rest of the tumors do. And here you see that Dr. McLeod, this I forgot to tell you, when on every Friday, there was a session in the morning when one of the residents had to present his work or progress in his work. And at this time, there was always coffee, there was tea, and guess what else? Cookies. So Dr. McLeod would always walk in and out of this conference room, and he would sneak out and get himself a cookie. And at those times, he would ask me, is there anything, he would talk to me about pathology, about urology, and he would ask me, is there anything new? He also wanted to know, can I help somewhere within this relationship? Can we do something which we could do better or what? And also I learned that he talked when he went to the CBDR headquarters. He walked around and he spoke with everyone who worked there. It didn't matter if it was a scientist, a cleaning person, or anybody in the building, he would say, hello, how are you doing? Are you all right? Do you need anything? And this is what he did with us. He did with me. And here you see one of those pictures where we had Dr. John Coffey as a visitor. And I think most of you know who Don Coffey was. There is Dr. McLeod, Dr. Brassel. We have Dr. Srivastava there, Dr. Jesior, who was chief of pathology of urology at the time. We have Dr. Petrovich, who was one of the first scientists who was hired for the CBDR, and Dr. Doby. Dr. Doby is the one who detected created the ERG antibody. And I remember he had 12 or 15 different clones. We had to find this one. And here is one picture, which I believe depicts something which is for me just incredible. This was 2 months before Dr. Mustafi died. There was a meeting of the government urologists, and Dr. McLeod brought everybody to the medical school here, to the conference room. And he spoke with Dr. Mustafi. And what this picture shows is their mutual love, respect, and he made Dr. Mustafi, even when he was in very bad shape, laugh and be happy. And this is what I remember about your husband. And I don't think that anyone will forget him. He will be just there. This is all I have for you.
Thank you, Dr. Session. Our next presenter is Dr. William Dayhut. Dr. Dayhut is the Scientific Director of the Center for Cancer Research and Director for Clinical Research and Head of Prostate Cancer Clinical Research at the National Cancer Institute. Dr. Dayhut.
Thanks for really the great privilege and honor of being here today. And I think what strikes me as we hear these really inspirational talks is that Dr. McLeod was incredibly hard to pigeonhole. We all kind of know who he is, but he kind of did everything. And I think that's really amazing. And I think as we hear the talks and all the things he did, it really strikes me, I think why he'll always be so important to everybody here. So what I'm going to do is also talk a little bit about a scientific paper, which we did years ago, which actually I looked at it again, it's actually fairly interesting. But what's really important is the legacy that he has with the connection of the NCI and the Walter Reed DoD program, because historically the NCI had a program down at the VA. They came out to Bethesda, and there was a time when there really was no longer the same interest between the folks at Bethesda and really our prostate group. And we sort of struggled to find a home, and all of a sudden Dr. McLeod welcomed us in, as he always does, made life easy for us, and it's really thrived. And that's who he was. He made things happen and made things better for everybody else. So let me see what my slides are. So this is historical. I think Nancy will get a kick out of this a little bit. I think Oliver, some other folks watching at home, this is a decade ago of a trial we did together. This was an idea of maybe combining drugs that block blood vessel growth with chemotherapy could work better. It was a time that there were a lot of trials then with docetaxel, the combination trials, and these were some of them that we were focusing on, looking at drugs that block blood vessel growth, anti-angiogenesis. Doug Fig, who I think is watching, was very involved in some of this stuff. So going ahead here. And so at the time, there was a large randomized phase trial in the CLGB, which gave a drug called bevacizumab. It was randomized against the control group. And as you can see, this combination had a better response rate, but patients didn't live longer. So what we wanted to know was, why this didn't work. Was it the wrong patients? Was it too toxic? Was it duration of the treatment was wrong? But maybe the tumor escaped. And so the idea was that maybe we could look at this graph that I think Doug Fig put together and others, and then maybe we could look at 2 drugs to block the blood vessel pathway, and maybe that would be better. So that was actually our plan here. And the idea was, again, looking at drugs like thalidomide and lenalidomide. Again, this is ancient history, but blocking angiogenesis and immune modulatory. And Dr. McLeod was very supportive of research, in chemotherapy, not something that he had been trained in. Preclinical work showed that it was activity. This was our study design, and it showed activity here as far as resistance and a lot of PSA activity. This is something here that showed almost all the patients, their PSAs went down dramatically, which was actually quite encouraging. But there were side effects there as constipation and fatigue. So we put another drug involved. This is the publication I was asked to talk about, lenalidomide, which is approved for multiple myeloma and other agents. We started in a phase 1 portion, fairly similar for metastatic patients with prostate cancer. Again, dramatic responses in PSA, changes in the liver, changes in the bone, reasonably well tolerated except for side effects. And when we compared it with other combinations at the time, very active. But as it works, this drug was combined without the 3 drugs together, and then it was a negative phase 3 trial. Bevacizumab was a negative phase 3 trial. And so angiogenesis sort of stopped here. And it's sort of interesting, we look back at this data, even today, it looks promising and interesting. And this was what Dr. McLeod always wanted to do, something better for his patients. So that's the science part of it. I want to talk a little bit about Dr. McLeod, and this is a little bit from a talk I gave, which actually was the last meeting I was at in person, about a year ago at the sport committee. And that was, how had things really changed in the last 20 years in prostate cancer? So thinking back at the year 2000, at the time, I know Nancy wasn't practicing yet, but some other ones had been. But at that time, there were no chemotherapy agents approved for prostate cancer. And the first robotic prostatectomy was actually done in 2000 in Germany. That was the very first one. We still were talking about combined androgen blockade in all our talks. The big JCO article at the time was Sermon. I don't know, Nancy may have been even on this paper. We never biopsied metastatic lesions. Our big radionuclide was strontium, and we used bone scans. Well, yeah, we still kind of use bone scans to look at assess disease. So where are we now? Well, we have docetaxel chemotherapy. We have basically one major agent. We're much better at targeting the AR, and so many of these things. Dr. McLeod was important. He was there was a time when urologists were very reluctant to actually have their patients receive chemotherapy, but Dr. McLeod was early on realized that this potentially could actually help them. He was very early on in the use of drugs to target AR, flutamide, high dose bicalutamide. This was stuff that he was passionately involved in. We now have intensified treatment of men with metastatic hormone-sensitive prostate cancer. People live longer by giving more intensive treatments earlier. That's something he believed in and drove. We now use active surveillance as a treatment option. This was something that took a little longer for people to accept, that maybe men didn't all need treatment for prostate cancer right away. But again, Dr. McLeod bought into this and was very accepting of this as a treatment option. We heard from Dr. Rosner about MRI targeted imaging the prostate. Again, something that once he thought the benefit for his patients, he did actively. Genetics, genomics of prostate cancer, the CPDR, the work we heard here from Albert and others, and from Dr. Susterhan. He very early became involved in the science of prostate cancer. And really, he understood as a clinician the importance of basic science, discoveries, basic science we would have in changing our fields. Again, he was a leader in this. Pharmaceutical imaging and targeted therapies. Again, the Prostate scan that Inger talked about earlier on. Robotic prostatectomy. He didn't invent it, but once he knew it helped, he was part of it. And then, stuff in radiation, and we all know he chose radiation for himself as a treatment option. He was a big believer in radiation too as a field. So even later on in his career, almost everything on here, I think you can see Dr. McLeod's fingerprints or drove it for his patients at Walter Reed. So then I thought about, for Dr. McLeod, and we could have like 100 things about Dr. McLeod that really struck me, but some of these things I think will resonate. Number one, he really never stopped being a physician. A lot of people, as they become, bigwigs like he was, they kind of walk by the clinic. He would be in his office. They were his patients. He's still in there writing their flutamide orders for 28 years. And
And they knew that he was this doc. He really cared about being a physician. And I think you'll see the legacy. When you look at Judd, you look at Nancy, you look at Inger, and you look at others, they're all real good docs. They're the ones that people go to because they care about being a physician. He always put his patients first. You know, if he didn't have the treatment or therapy that was right for the patient, he would reach out to somebody else. He would talk to the oncologist, the radiation folks. He would find what was best for his patients. So I think, you know, he didn't feel an ownership. He felt an ownership that they would do well, but not an ownership that he had to be in charge of it. And he was a soldier. You know, it's interesting. You know, I was in the Navy, and we were physicians. We were sort of in the Navy. You know, we wore Argyle socks. We had our hair long. You know, but he cared about the tradition of the military. He cared about the tradition of being a soldier. It was important for him to be in the Army. He understood what that meant to his patients. He understood the culture, and I think it resonates in what he did, sort of the act of service. He shared credit. You know, we talked about it earlier on today with Dr. Sesterhain and others. You know, he kind of liked to make things happen. Yeah, he needed his name on the papers if he had an impact, but he had no problems in sharing credit. He didn't take an easily no for an answer. Nancy told the story earlier on when she was going to go ahead and run the DoD breast cancer stuff. You know, he would call this person, that person. You know, he didn't just simply back up and say, well, I guess that's the Army, that's what's going to happen. No, he would make things happen. And he understood the importance of being in Washington, D.C. He understood he was really in a very important part, that he could have an impact not only on his patients, on his institution, but on the field overall. And again, the stuff that Judd talked about, you know, talking about the centers he took care of. And he understood his role in that position, you know, not necessarily to be in charge of the hospital or in charge of the base, but he as a physician could really impact on being of importance. He understood basic science research. And now it sounds obvious, of course that's important. But, you know, if we go back, you know, 20, 30 years ago, there was really a dichotomy between what the basic scientists were doing and what the clinical folks were doing. And, you know, there really wasn't a sense that a lot from the basic scientists that what they were doing could have an impact on patients. And he understood that it could. And the fact his legacy at CPDR is quite important. He understood collaboration outside the military. He didn't stay siloed. And I think you'll see the folks, you know, we have David Crawford, we have Oliver Sarter, obviously the folks of us across the street. He understood that the military had a role not only in the care of the military patients, but overall in cancer care throughout the world. And he talked about that. He supported the people who worked for him. Again, he made sure that, you know, we talked to Isabel and others talked about everyone who worked for him. He would do what he could to help, you know, him or her's career in any way that he could. And so, you know, we hear again the little stories, you know, Judd going down to do a fellowship, and, you know, and then, you know, Nancy not going to the DoD stuff. And then, you know, Inger examples of her getting on papers, and others here too. So he understood about taking care of his people, not for benefit for him, but for what they meant to them. And then he never stopped caring. You know, he always cared about his patients. He always cared about his people. He always cared about the science. So, and I think that's why he had such a great impact. And that's why we can't, you know, there are people out there we know in science, and we say, well, you know, they made this discovery, or, you know, they were really good at this. But all of this encompasses why he's such a special person. So, so those are my thoughts, and thank you very much. And, you know, that's where I hang out. So thanks a lot. Thank you.
Thank you very much, Dr. Dayhut. Our next presenters, I'm not sure if they're online. These are the virtual presentations. Dr. Nivan Narain and Michael Kibish. And gentlemen, we have you online. The floor is yours.
Evan, I believe you might be on mute.
Hi, yes.
Hey. Morning, guys.
Good morning. Welcome to the presentation. You have the floor.
Is it? Sorry, Mike. Is it mine? Hi, well, welcome. It is such an honor to be here to commemorate the life and the career of Dr. McLeod. It's I should start off by saying the most impressive thing for me for Dr. McLeod when I initially met him is that you very quickly realize that one does not necessarily have to be one of his official fellows of students or students to feel like you were. He certainly impressed a bridge of innovation that brought together Berg as a company in the industry to start which was back in 2014, a collaboration between Berg and the Walter Reed, specifically the CPDR. And the original agreement was signed at a time when the IRBs were being merged as one between Bethesda Naval and the Walter Reed. With his help and guidance and his thoughtfulness, he was able to help individuals on both sides understand what that meant, how to overcome some of the challenges. And in the time that we were lucky to interact with Dr. McLeod and his team, Berg has actually gained access to tissue samples and biofluids, and collaborating with with members of CPDR to actually discover and validate a group of biomarkers that is now been able to demonstrate the ability to segregate benign prostate hypertrophy from prostate cancer. That work, which is now going to be advanced into a commercial view, is in large part, if not almost entirely, the hard work of Dr. McLeod and General Elder Granger, both of whom we've been so honored to work with. And I would just hand it off to Dr. Kibish now, who is going to go over the rest of the presentation. But I would just like to end my initial thoughts by saying his arc of legacy not only is going to continue from a scientific and a clinical perspective, but I think just listening to some of the earlier speakers, he will be carried through the rest of our careers. Thank you. I'll hand it over to Dr. Kibish now.
Well, thank you, Nevin. And just from a technical perspective, I'm having trouble sharing the screen, and it will not allow me to share from my computer. I don't know if anyone's able to allow access.
You should have access now.
Oh, there we go. Thank you. No, thank you again. It's truly an honor to be here today. It's been a pleasure to work with the CPDR team and Dr. McLeod, being mentored by him, being a colleague, and also really engaging the evolution and the approaches to investigate prostate cancer. As Niven mentioned, we embarked on a very important CRADA where we went beyond just genomics. We wanted to really treat the patient, not just the disease, and look at the systems as a whole and how the integration of multi-omic data sets actually came together with artificial intelligence and Bayesian AI. And this was really embarked in a 5-year CRADA where we investigate several hundred biofluid samples. We investigated a lot of the work with Albert Doby and the CPDR team, and Shiv and George and Jenny on ERG, and how the molecular biology, the biology around the patient, really came together. And this was, again, done through the high quality biospecimens and biofluids and tissue samples integrated in, working with Berg on our multi-omic capabilities. One key aspect of the CRADA that led to something we're very proud of, and I know Dr. McLeod is very, very proud of, was the embarkment of the David McLeod Translational Research Fellowship, which Dr. Prachi Mishra spearheaded this effort. And I know from personal conversations, Dr. McLeod really enjoyed going into the office, mentoring, talking science, talking cell biology. And his images from the kickoff of the fellowship. But it really was all about the exploration of science, being a purist in nature of what science is all about. What is the cell biology telling us? And these were some of the outcomes from that fellowship, but also being able to publish. Publication is absolutely key. That's the currency of science. And this fellowship allowed additional publications to come from our collaboration and investigate key aspects of biology. The presentation today was really focused on one particular paper, even though we've had many with CPDR, which we admire every single one of them. This involved a multi-omic analysis of serum for the prognosis of disease progression in prostate cancer, biochemical recurrence. And this really came from how science is supposed to be done, in a room with a whiteboard, realizing that you have data, there might be an opportunity to extract much more insight back to the patient. And it came from one fateful day, one fateful trip down to Rockville at the time, and realizing we had several hundred patients who we had run multi-omic data sets. And Jenny, Shiv, Albert, and Dr. McLeod realized that we had quite a pool of patients that had biochemical recurrence. And then we wanted to kind of essentially stratify those patients using multiple different omic technologies and Bayesian AI. And as we are all aware, there's a critical need in prostate cancer for early diagnosis, but also even more so for things such as biochemical recurrence, identifying the patients at risk who are not at risk with their NPV scores, and truly avoiding unnecessary biopsies, as Niven mentioned. Part of our collaborative research really was focused on men at risk that had a high PSA but didn't have cancer. And so the study design of this particular investigation really was looking at men who had confirmed biopsy prior to radical prostatectomy, analyzing the serum and doing these multi-omic technologies, and assessing risk prediction. We had 382 men, of which 72 experienced a biochemical recurrence event. And we essentially wanted to integrate this through the Bayesian AI and through diagnostic utility. And just from a process perspective, this was a team effort in terms of transfer samples with Ms. Amina Ali and integration and analysis through multi-omics. Several million data points were identified. And essentially, through the quantitative data, they were put through our AI engine. And I know this looks like the Whopper from Matthew Broderick's War Games, a little image down there, but it's not. It's really generating de novo insight using causal inference, generating connections and then connecting to a greater network, developed network topology. But we really truly do not understand the integration across all omic data. It is, again, the system of the patient that comes together, connecting clinical endpoints, outcome endpoints with lipid-based data, metabolite, a comprehensive proteomics. And this is what we wanted to really approach. And this is really a novel approach to clinical insight, going beyond what is known and not just correlation, it's really causation. And this process essentially drove into much more advanced analytics, integration with a network biology and in the conventional diagnostic utility in terms of defining PPV, NPV, odds ratios, and AUCs. And an important finding, just showing the conventional kind of differential, we found markers within the metabolomics in these patient serums, methyladenosine, which is a known driver for DNA replication, has been implicated before. and this was elevated in the biochemical recurrence patients. Proteins such as tenascin C, the apolipoprotein were elevated. A very interesting point was this investigation spawned the interest from the genetics of tenascin C, which led to another paper in Genes in Cancer from the fellow Dr. Prashi Mishra, which we found that there was a high level of amplification of tenascin C in prostate cancer patients, especially with biochemical recurrence and more aggressive cancers. So reverse engineering the adaptive omics back to the genetics was really another outcome of this process. Same thing with a novel lipid, phosphoric acid 18022O. This is involved in immune regulation and inflammation. So clearly there's a systemic effect that the body is recognizing for biochemical recurrence. Again, this goes beyond just the tumor alone, is how the body is reacting to the process. And with this, essentially a defined panel was developed around this, around the 4 molecular markers. We're developing an AUC of 0.78 and an odds ratio of 6.5. But with the Bayesian AI, we recognize that there's other clinical features that could be coalesced and integrated into a panel, which in the end came down an AUC of 0.89, an odds ratio of 12. Together, these multimodal, multimolecular, and integrated dynamic kind of panels form the diagnostic predictability. This again formed a patent and intellectual property and the pursuit of a commercial product around utilizing this data. So the combination of all these different entities, just beyond genomics, was really the vision of the collaboration to use the clinical data to the greatest extent. I give tremendous credit to the team because the vision of Dr. McLeod and how well the team worked together from the sample origin, and I never will forget Miss Amina Ali saying that there's really a promise for every sample that's collected to each individual that it'll be used for the greater good, that it will be used fully. And that mission truly ran through the entire team at CPDR from every single member. And I think we, as a collaboration with Berg, really embodied that. And we actually discovered multiple different entities, published multiple papers, and even submitted a paper last week with Dr. McLeod on it for one of our collaborations. So I think his legacy by far is everlasting because of the training he's given, the scientific spirit that he's done, and essentially the next generation of scientists who are now purists to the scientific craft. And I'll end by thanking the entire CPDR team, the mentorship of Dr. McLeod, the friendship and collaboration he's given, and the support from Dr. Shriver and Dr. Elser, and of course, the Berg team, Mr. Carl Berg, Dr. Sararanjan, and Dr. Paul Song. Thank you.
Our next presenter is Dr. David Crawford, who's a distinguished professor of surgery, urology, and radiation oncology at the University of Colorado. He'll be presenting virtually. Dr. Crawford, the floor is yours.
Good morning, everyone, and thank you very much for this great honor and pleasure to recognize one of the real leaders in prostate cancer. And so I want to just go through that paper that Judd Mal mentioned that was in New England Journal of Medicine. So if I could have my slides, please. I think I sent them in. If not, I can show them from my computer.
We'll allow you to share your screen from your computer.
All righty. I'll see how technically wonderful this is. Okay. All right. All right. Does everybody see him here? All right. I assume that
We see your slides.
Okay, thank you. Looks like they're in presenter mode or something, but we'll try to work through it. Anyway, My name's Dave Crawford. I'm currently a professor of urology at University of California in San Diego. Dr. McLeod always likes to poke fun at things and have a little joke in that, so I have one right here. And this is, as you well know, California is converting to all electric cars in the next decade. This is a picture of that I took on the 405 freeway of an all electric vehicle being towed by a gas guzzling Suburban. So anyway, David would appreciate that. I was asked to talk about this manuscript, which was really a game changer that David was part of in New England Journal of Medicine. And it was a trial that we all worked collaboratively on. I'd known David for a number of years. We started the Prostate Cancer Education Council back in the late 80s. And also he worked with the National Prostatic Cancer Group. I was the head of the GU committee of the Southwest Oncology Group. And we developed this trial to answer an important question that was out there regarding anti-androgens. And I want to spend the next couple of minutes talking about those. Androgens, testosterone is sort of the key in prostate cancer. Testosterone is the king. And we had believed that most testosterone came from the testes, and we heard a little bit about this already, that you could do bilateral orchiectomy or in fact do things like estrogens to block testosterone. We also knew at that time that the adrenal gland did produce testosterone also, and the importance of that was hotly debated for a long time. And it led to the development of some new drugs called anti-androgens years ago. And David was a pivotal person in the development of anti-androgens. Here next to him is Dr. Fernand Labrie, who was really the stalwart of supporting the use of anti-androgens in combination with an LHRH agonist or other therapy to treat prostate cancer. And people were flocking to Canada to get this new drug flutamide, which was not approved in the United States. And we have here sort of in the bottom of this slide, this sort of the history of anti-androgens. It really starts back with the development of orchiectomy and estrogens in the 40s and the Nobel Prize. And then right here we see that flutamide was developed in the early 80s. And the idea was that would block testosterone, dihydrotestosterone of all sources. So what we have here is a situation where we have the, whoops, something got lost there.
Dr. Crawford, we're not seeing your slides advancing. If you'd like, we can pull them up from here and just advance based on your direction.
Okay, why don't we do that then? Sorry.
Give us 1 second. We'll catch back up.
Okay.
And we've got you on slide 5 now, Dr. Crawford.
Okay. At any rate, so what we know is that testosterone, the most of it is produced by the testes, 95%, maybe 5 to 10% by the adrenal gland. And the concept of combined androgen blockade that David was critically involved in the development of that was to be able to block all testosterones. And that led to this large study, which was published in the England Journal of Medicine in 1989. And can we have the next slide, please? So what we know is that androgens, testosterone is chaperoned into the cell and then converted to something called dihydrotestosterone by 5-alpha reductase. And it is then chaperoned into the nucleus and promotes messenger RNA and protein synthesis and so forth. So the idea with combined androgen blockade and an anti-androgen was to neutralize not only testosterone of testicular origin, but also testosterone that was made by the adrenal gland, and later we learned also was made by the tumor itself. So the next slide. This is a study that I've already shown, and I must say this is probably one of the game-changing studies of that decade, and one that was truly a cooperative group effort that David was pivotally involved in, and finding out in the next slide is that when you added this early anti-androgen called flutamide to our standard therapy of lowering testosterone with leuprolide, you had a 26% improvement in overall survival rate or over 6 months. That was a game changer back then. But the problem is there was a lot of reasons it wasn't accepted, including the cost of a couple $100 a month. Now we're paying $10,000 a month for similar drugs. And the other thing is that we did a study later with bilateral orchiectomy that did not show that big benefit. We didn't know why, and that sort of pulled the rug out from under this. We published that in the England Journal of Medicine too. But we found out later that it was really due that bilateral orchiectomy is not a great treatment for prostate cancer because of the elevation of FSH, and we worked on that. Next slide. So what David and Judd also, and I'll talk about that in a minute, spent a lot of time studying monotherapy with anti-androgens, because when you really think about it, if you had something that blocked the receptor completely, then that's all you need to treat prostate cancer. It'd be very effective. The problem with these things are that they were competed off. And the other thing is, you can see here a man with gynecomastia. When you give an anti-androgen alone, you raise testosterone, and that's aromatized to estrogens, leading to, in some men, this gynecomastia, which you see on this slide. Next slide. So what we, and Judd mentioned this, that one of the last publications that David was on was this one, which was just published in the Journal of Urology a few years ago, which brought together all the people in the history of anti-androgens that really were the pivotal people that got this started. And it's a group from Europe, the United States, Canada, and also Dr. Labrie, who is the senior author here, who just died last year. And this paper really outlines all the impact that this has had. And a number of the people here are folks that really paved the way, and Judd and David and others. Next slide. So anti-androgens, I'll just finish up here, can be either steroidal or non-steroidal. And Nancy Dawson mentioned a steroidal one and how it behaved, and that was megestrol acetate or Megase. And then the non-steroidal ones are ones that didn't have estrogen-like effects. They were directly targeting the androgen receptor, and they didn't have some of the other side effects that you see with progestational agents and other steroids. Next slide. So the androgen monotherapy was studied, and David was really a leader in this, and that got Judd and I interested in it. And Judd and I worked together on a monotherapy trial we published. Actually, there's been 2 publications on it, using anti-androgens alone to treat prostate cancer, and it's still utilized. But we were hoping to have a more potent anti-androgen that would work without using Lupron or drugs like that. Next slide. So again, this is Tia Hagana, who's worked with us in this, and what we see now, if we've come a long way from where we started in '80 with the steroidal anti-androgens, Megase, cyproterone acetate, to the non-steroidal ones. The first generation we studied was flutamide, second generation. A lot of work that David did with that large bicalutamide study, and now we're into probably one of the more important treatments for advanced prostate cancer, and that's the 3rd generation anti-androgens. Next slide. So what the first one we mentioned was flutamide. There's Mario Eisenberger there up in the left from Johns Hopkins, who worked with us very closely in this. Dr. Neri discovered it in 1967. And, but it really wasn't a great drug. You had to take 2 tablets 3 times a day. 25% of people got diarrhea, but it was the step forward, and it was sort of the beginning. Next slide is the second generation ones, and David and Judd did a lot of work with this monotherapy studies, huge monotherapy studies with bicalutamide around the world. 16,000 men were studied various stages of prostate cancer, and it really did make an impact. And it's something that's being utilized today still. Next, we have now we have third generation, and that's what's making the difference. These are enzalutamide, bicalutamide, and apalutamide, and they're a key part of our treatment for advanced prostate cancer right now. And that was really paved by that study that I showed you a few minutes ago in New England Journal of Medicine. Next slide. The enzalutamide and is a third generation anti-androgen. It's very selective. Next slide. It's being used in a lot of clinical trials. It does have some side effects, as many of these drugs do, but it's sort of becoming our go-to drug with the LHRH agonists and other things in advanced prostate cancer, which all began with this study back in 1989. Next slide. And so there are a lot of current trials ongoing that with these anti-androgens, and what we're seeing is that they are moving up from the worst case metastatic castrate-resistant disease to metastatic and now biochemical failure and even localized disease. Next slide. So the future therapeutic options with this, and Dr. Paul Shellhammer, who was an integral part of all this work, a good friend of David and mine, was another leader in this area. We're very proud of where we are right now with anti-androgens, and proud to be part of that 35-year history in that paper. Next slide. So I want to say a few words about David as I end up here. I've known him since the late 80s. If you look here in the top, 1999 Munich, do you believe that they convinced both of us to put on lederhosen and dance in front of a group at the Munich Beer Festival? Well, I think David and I had a lot of beer. That's the only reason we did it. And then in 2017, one of my last meetings with David was at the AUA in Boston. And there's a picture of the two of us. We were planning and working on that great paper I just showed you, that 35-year history of anti-androgens. And he was so proud of that. I think it really perked him up, and Judd gave me some insight into how he felt really needed and wanted, and contributing to that. We appreciate that. And he did that. Next slide is we were part of a lot of meetings, and here's a kind of a joke slide. It was about the aging male, and had the arrow up, and I turned it and pointed it towards David, so he closed his eyes so we wouldn't get a good picture of him. And that was some almost 30 years ago. But it goes to show the value of testosterone in men, and it continues to understand hypogonadism and the effect of it on prostate cancer. And to the right there is General Bernie Mittermeier, and I've got my hat on, Make PSA Great Again. We sent that to David for all his help in making PSA great. So with that, next slide. It's kind of sad to say this, but David, we miss you, and you will always be cherished for being you. Thank you.
Thank you very much, Dr. Crawford. Next, we'll turn our attention to our next presenter, who is Dr. Anthony D'Amico, who's professor of radiation oncology at Harvard Medical School.
Thank you very much for this opportunity, first of all, to be able to speak just for a few minutes. not only about the academic pursuits that I was really blessed with to partner with Dr. McLeod, but also a little bit about him as a person. So what I'll do here is you can show the first, I have one slide, and if you want to show that, that would be terrific. The way I met David was really through the first speaker you heard earlier today, and that was Dr. Judd Mao. And Judd, you know, obviously at that time was a urologist who was working closely with Dr. McLeod. And I met Judd, you know, through some research we were doing at the AUA, and found out that there was this database that existed within the Center for Prostate Disease Research that David oversaw for decades. And he said to me, I talked about some ideas, and he said, gee, you know, let me introduce you to the person who runs this. Come down, give a talk, and let's see what's possible. And, you know, so from that came a number of studies, not just one or two. There's two that are sort of listed in the program, but there were many studies. And the gist of it is that we're learning at that time that when a man was treated for prostate cancer, whether it be with surgery or with radiation, there were certain aspects in the follow-up period with respect to a measurement of a blood test called PSA that told us a lot about whether that gentleman was going to recur, and if they were, whether that recurrence was likely to be within the area where the surgery or the radiation was performed or elsewhere. And this was the construct of how fast the PSA, when it returned, if it returned, was rising, called the doubling time. But even more than that, we didn't even realize at the time something back in 2005 that would become the basis for clinical trials today, and that is how low the PSA dropped after surgery or radiation, called the PSA nadir. And what we learned was that the lower it went, the less likely the person was to ever suffer a recurrence that would impact their life in a meaningful way. But the higher it was, the more likely they were to die of the disease. Because what we've come to realize is that if the PSA did not drop to a very low level after surgery, that is undetectable, or after radiation and hormones, that there are residual cells, some of which may already be resistant to treatments that were currently available at the time. What's shown here on the screen is a randomized trial that is currently running. It's multinational, multi-institutional, and it's really based on the work that Dr. McLeod allowed us to be able to do with the CPTR database and also his insights and his collaboration. Basically, this is a study where men who have the kind of prostate cancer that you cure often but not always, so-called high risk, are randomized to, after they've received their first course of radiation and 6 months of hormonal therapy, are randomized to continue on that hormonal therapy for the 2-year course, or to continue on that hormonal therapy and get novel agents called apalutamide, abiraterone, next generation androgen receptors, blockers. Because those men who are randomized are those men whose PSA never nadirs, never becomes low enough that we're assured that they are unlikely to ever suffer recurrence that will cause them spread of the disease and potentially death from the disease. This study is very novel because it is using the information about a biomarker, how low does the PSA go, in this case after radiation and hormones, which tells us a little bit about the future. This is the first clinical trial of this kind. Clinical trials to date enroll men at initial diagnosis or at recurrence. But this trial enrolls men while they're still undergoing treatment for their disease and before they recur, but based on a biomarker at high risk for recurrence. And so this study is, being partnered with the Canadians, multiple sites throughout the United States, and all made possible because of a construct that Dr. McLeod helped to enable all of us to be able to discover. and that is the value of how low PSA falls after radiation and hormonal therapy. And I just want to make a point to say how important it is and how long it takes clinical science, to advance. That PSA nadir first paper was written back in 2005. This trial was launched just about a year ago and will accrue over the next several years, and we'll have some information on its importance probably somewhere in the 2027 to 29 range. That's 25 years, really, from the time in which it first began as a construct. But that's okay, because if it takes men who are likely to die of the disease and give them another chance at cure by finding them early on in the disease process while you're still treating them literally with your initial treatment and giving them additional therapies in real time before their treatment's complete, that would be terrific. So that's all I'm going to say on the science, but I do want to say a few more things now on the person. You can turn off the slides, and that way people can focus just more on the screen. Thank you. So I want you to know a few things about, Dr. McLeod that I really came to appreciate. First of all, he was a man who always enjoyed a good joke. And I'm not telling a joke today because it's a different kind of event, but we would get together at these various meetings, and before I gave a talk, I would always say something, a joke, and then he would come back with something as well. I want to share another personal vignette about the other side of David. I mean, he's intellectually brilliant, amazing leader, but there's human sides to him that I really appreciate and that I have learned how to embody in myself and how to pass on to others, so that his life not only advances science, but advances humanity. And while science is important because it impacts people and their lives, humanity is essential because it's what holds us together as a people. So here's another thing I'll never forget. I was invited back to CPDR at a time when they were honoring, just like we're honoring David today, they were honoring Dr. Mustafi, who came up with a grading system for prostate cancer. And at that time, Dr. Mustafi was ill. And I remember Dr. McLeod introducing Dr. Mustafi as he came up to give a talk. And David had known, Dr. Mustafi for many, 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 many years, and I believe he was a mentor to him. And seeing how ill Dr. Mustafi was, and still trying to give this talk, which he did and did well, and was brilliant, there were tears in David's eyes towards the suffering that he saw going on in Dr. Mustafi, because he had the disease we're talking about right now, and he had the disease into areas of his body that were causing him some discomfort even to stand. David's heart was amazing, and I got some insight into it that day. I also learned from Dr. Mao, you probably heard earlier, about how he mentored him. And so what I want to say in closing is this. There are many things that we can honor Dr. McLeod for. His military service, his leadership, his scientific brilliance, his expertise as a physician. But I want to just remember one very important fact, and that is the part that will transcend all time. And that is the way in which he genuinely loved the people that he mentored, the people that he cared for, the people that he oversaw and directed, his sense of humor, his ability really to reach out and touch people in a way that only he could. And I still remember, because I was still pretty young when I first met him. I was just became an associate professor, and I still had a ways to go in terms of learning, and how he sat me down in his office and talked to me a little bit about my goals, my aspirations, and then we talked about science. And he was very supportive and very, very, very warm and genuine. So when I think about a life of somebody, who I think about emulating and passing on, David is right there, in the top of that list. And I want you to know that everything he gave, in addition to science, but what he gave as a human, still lives on in me and lives on in the people that I mentor. And so while then many of the people I mentor will never know, as I had the blessing to know Dr. McLeod, they will know what he stood for, and they will know what he represented, and they will learn to embody that in their lives. So despite the fact that he's gone, His presence, his essence, what he stood for, lives on in me and countless others as a result of how we take what he gave us and pay it forward. So I want to thank everybody for this opportunity to really honor someone who was not only an amazing physician, scientist, clinician, leader, but also an amazing human. And I know that where he is right now, he's smiling because he knows that his life is not forgotten, lives on in all of us. Thank you.
Thank you very much, Dr. D'Amico. Our next presenter is Dr. Axel Heidenreich. He serves as a clinical leader for urologic oncology and professor at University of Cologne in Germany.
Yeah, ladies and gentlemen, I hope that you can see my slides. Dear family of Dr. McLeod, when I entered AFIP, Walter Reed, and Justus back in 1995, I was kind of the exotic guy as I'm today. Everybody is talking about prostate cancer, and now I'm going to give a presentation on testicular cancer. And this is how I started at Justus and Walter Reed back about 25 years ago. I just was a young research fellow coming from Germany, being focused on testicular cancer. And David McLoud, Judd Mowell, Isabel Sasterhan, and also Kash Mustafi did allow me to perform my studies. And this is the paper I was asked to discuss with you. It's just the role of retroperitoneal lymphadenectomy and meteoroteratoma of testicular cancer. And what I would like to do, I would just briefly reflect the paper itself and the science of the paper. I will give you some thoughts about which impact this paper had and still has in the treatment of testicular cancer. And I also would like to refer a little bit to the impact David McLeod and the CPR team had on my career in uro-oncology. Just because everybody was talking about prostate cancer, I will give you a brief review on the characteristics of meteoroteratoma. It is a rare lesion, only making about 5% of all testicular germ cell tumors. It is very often a combination of cystic and solid lesions. And as you can see on the right side, it's a slowly proliferating tumor. It is characterized by early lymphatic spread and late hematogenous spread. And about 1/4 of patients will have metastatic disease at time of presentation. Back in the 1990s, the treatment strategies were quite simple. In clinical stage 1, there was a controversial discussion between oncologists being in favor of active surveillance and the uro-oncologist being in favor of primary nerve-sparing RPLND. For those patients who had low volume metastatic disease, there was a discussion between primary chemo followed by post-chemo RPLND, or just the other way around, primary RPLND followed by chemotherapy. So we did ask the question, what was the frequency of metastatic disease in pure meteoroteratoma of the testis? The other issue of our paper was to identify predictors for metastatic disease in low-stage meteoroteratoma to allow an individualized risk-adapted approach even 25 years ago when nobody was talking about individualized treatment, and we focused on the outcome of therapy. So we went into the database of the AFIP, and we identified 44 patients out of the cohort of 772 patients who had pure meteoroteratoma. About two-thirds of the patients had clinical stage 1 disease, and about 1/4 of the patients had low volume metastatic disease. We did perform nerve-sparing RPLND in all patients with clinical stage 1, 2A, and B, and we did start patients on primary chemotherapy with advanced metastatic disease. And just to give you an insight how it looked like, how the surgery looked like at that time, on the right side, you can see the nerve-sparing approach in clinical stage 1. You nicely can see the sympathetic chain, the ganglia, and all the sympathetic nerve fibers running ventrocodally to the aortic bifurcation. And even in patients who have metastatic disease, we can perform a nerve-sparing RPLND, and this has become the current standard nowadays for the management of those patients. These are just the most important data of our study. we did demonstrate that about 1/4, about 20% of those patients who had pure mature teratoma, and at that time, teratoma was thought to be basically benign lesion without metastatic potential. So we could demonstrate that about 20% of those patients in clinical stage 1 disease had metastatic disease, occult retroperitoneal disease. We could demonstrate that about 2/3 of those patients who had clinical stages 2A and B had metastatic disease harboring teratoma. So basically, all of those patients who had low volume disease did harbor teratomatous elements in the metastatic deposits, which is important to know because teratoma is radio and chemo resistant. So you only can cure those patients with surgery. As I said, we wanted to identify predictive markers for metastatic disease. So we went back to the orchiectomy specimens, did serial sectioning, and tried to identify pathological specifications which might be associated with metastatic disease. And we came out to the finding that those patients who have mature teratoma associated with scars or calcifications close to the teratoma, or those who had small microscopic foci of other non-teratomatous elements, were the ones who developed metastatic disease. Whereas those patients who only had mature teratoma as the single pathologic lesion in their testicle basically never had metastatic disease at time of diagnosis. So the presence of scars, calcifications, and microscopic foci of non-teratomatous elements turned out to be risk factors for metastatic disease. And this is how we develop this type of individualized therapy. So stage 1 disease, you look for burnt out tumor in the primary orchiectomy specimen. If it is present, you perform a nerve-sparing RPL&D. If not, you go for active surveillance. If you have marker negative stages 2A and B in mature teratoma, you also start with nerve-sparing RPL&D. So did this study have any impact on future treatment in patients with teratoma or advanced testicular cancer? Yes, it had. As you can see in this slide, we, with our paper back from 1997, made it in the guidelines of the European Society of Medical Oncology. And these are the actual guidelines published in 2018. And they still refer to this old paper, which we, together with Dr. McLeod, published in the mid-90s. We also learned from all the studies I was allowed to perform at Walter Reed, AFIP, and USUS with the help of David McLeod, that whenever you have a growing teratoma syndrome, complete resection is mandatory to save a patient. And this is just a picture of a growing teratoma syndrome in the retroperitoneum, in the retrocrural area. And if you perform a proper surgery, which is depicted on this side, where you just completely remove this teratoma as an en bloc resection, and when you go to a thoraco-abdominal approach to just remove this large retrocrural mass, we know that we can cure patients because we know about the specific needs of surgery, as we pointed out in the initial paper. Based on the studies at the AFIP, we performed a risk-adapted surgical strategy, which also made it in the national and international guidelines, a modified or radical bilateral template based on the presentation of residual tumor lesions after chemotherapy in patients with advanced testicular cancer. Last but not least, we demonstrated also based on the studies we performed in the 90s at the Walter Reed Army Medical Center that complete resection of metastatic lesions independent on their anatomic situation will cure patients. And you don't increase the treatment-associated complications even when you perform complex surgeries. Nowadays, we try to use artificial intelligence to identify patients who have benign and malignant lesions. And by using this type of radiomics, you can see that there is a very high accuracy to identify patients with benign lesions and those with radio-resistant and chemo-resistant teratoma. So we can save many patients from surgery by just using radiomics. We also integrated molecular biology and this is one thing I extensively learned at USUS and at the IFIP with the help of Schiff and Isabel Sesterhan. We go into microRNA, and when we use microRNA 371 and 375, we only misclassify one patient with vital disease. We only misclassified one patient with teratoma and only one with necrosis. So the molecular biology we learned back in the 90s is still alive in the 2020s. So at the end of the presentation, I really would like to thank Dr. McLeod and the CPDR team who gave me the opportunity 25 years ago to do research in testicular cancer at an institution called Center for Prostate Disease Research. And he told me that only from the valley, the mountaintop seems to be very high, so you need to use all your efforts to reach your goals. And sometimes without support, it might be that the way down or the way to achieve your goals might be obstructed. However, if you take all your efforts, it will result in excellent views, it will result in an excellent career, and with the support of confidence of people like Dr. McLeod, there is always a way which could lead you down to your goal and just to your goals. So at the end, thank you very much for the attention. Thank you very much for giving me the opportunity to be part of this scientific meeting, and to just say my thanks to Dr. McLeod for giving me the opportunity to start as a research fellow and then to build up with his help, with his support and mentorship, my career in uro-oncology. So thank you very much for the attention.
Thank you very much, Dr. Heidenreich. Our next presenter is Dr. Ian Thompson, Jr. After his career in the Army, Dr. Thompson has served in various roles in the urology community and is currently presenting from Texas. Dr. Thompson, over to you.
Well, good morning. It's nice to see everyone virtually, and I'm going to let you draw the slides, and I'll just do the next slide. And this will be very brief. It's a real treat to be here and to be amongst such a great group of folks. Great talks, everyone. The paper that I was asked to highlight is the second of the two New England Journal papers from the Southwest Oncology Group and the national, what was the NCTN at the time, which was the cooperative groups. Next slide. We're taking it back to like the prehistoric era. And we have to remember that prior hormonal therapy was either orchiectomy or that should have been estrogens. And that was the standard of care when I was a resident. We would just, and I started in 1980 or so, and we would do orchiectomies. And I can remember the first reports of the LHRH agonists because I went to medical school at Tulane, and that was where Andrew Shalley in his laboratory, interestingly at the VA across the street from Tulane Medical School, had done his work on the structure of hypothalamic hormones, and it led to the development of the first LHRHs. And I see some nice young folks. They're the future of our specialties that are attending this. And most of those folks don't remember, well, they couldn't because they were quite young at the time. We gave those agents daily when it first came out. And that was obviously a real challenge. And it led to some other things. But it very rapidly replaced orchiectomy and it became the standard of care. Next slide. And in the 1980s, as Dr. Crawford pointed out, Fernand Labrie was one of the first folks to report on the use of combined androgen deprivation. And he added some of the steroidal anti-androgens, and quite a few, to the LHRH agonists, then the non-steroidals. And it was used in response to the recognition that because after orchiectomy, we all know that tumors become castrate resistant. And Kathy Tang and David and I published a paper that looked at the overall survival of patients in the NCTN clinical trials for for hormone-naive prostate cancer. And we noted gradual improvement in overall survival, but virtually every like 90% plus of the patients became castrate resistant. And Dr. Labrie was one of the first folks to say, well, why don't we use it up front rather than as salvage, and suggested that there was improved outcomes. And as David alluded to, in the early to mid 1980s, many of our patients were hopping on airplanes and flying to Canada, where they could get daily Lupron and flutamide, generally speaking. Next slide. And so here's one of the first papers from 1985. It's a combination therapy, and you see Dr. Labrie as the first author. A lot of his papers were published in the endocrinology literature. Next slide. And so if you look at the clinical trial design, it's very important to recognize that it was not what we would expect today, but it was, things were different back in those days. And between 82 and 84, he took 94 patients with newly diagnosed metastatic prostate cancer. 87 were previously untreated, and they were kind of randomized. Not exactly certain how this occurred, but there's 77 got an LHRH agonist and flutamide, and 10 got orchiectomy alone. Next slide. And so there were a series of observations, and this Kaplan-Meier is pretty graphic. You notice it goes to about, what is that, 118 weeks of treatment, so a couple of years or so. But you notice that the patients who got combined blockade had really remarkable outcomes. And if you had an orchiectomy alone, all the patients were dead in a couple of years. So that was an interesting observation. Next slide. And then he began to assemble larger groups of patients and began to compare with prior series, which is obviously hazardous because that's how some of the observations that we made about other therapies when we compare existing therapies in contemporary groups of patients with prior groups. But here's his outcomes in the combined androgen deprivation, and then you see DES, estrogen, and Lupron, dramatic differences in whether the patients had a continuing response. Next slide. And then in a 1988 paper, so this is 3 years later with more experience, next slide, again in the endocrinology literature, you see again these really remarkable differences between his experience and historical controls. Again, hazardous to do that. We now would not do, well, we hope we would not do this, but back at the time, it's really kind of all that you had. And then as you looked at the differences in continuing response compared to bunches of other trials, the EORTC, the European trials, really huge differences. Next slide. Again, none of these were randomized. And here's the risk of death from prostate cancer. And you see really dramatic differences at 4 years of follow-up. We're talking 50%, 40 to 50% differences in the number of patients that are still alive. Next slide. And so the Southwest Oncology Group, along with the members of the cooperative groups, now what we call the NCTN, and Dr. McLeod was a member of that group of individuals and was very much an advocate for participating in NCI clinical trials, responded, and tested that hypothesis that combined androgen deprivation improved survival of hormone-naive prostate cancer. Next slide. And so this was the paper that Dr. Crawford highlighted, and just you have to remember the contributions of Dr. Crawford as well. And so he and Dr. McLeod were, I won't say they're contemporaries, but they certainly were the icons of urology and prostate cancer and medical oncology at the time. And this was this trial that David reported on that showed this really splitting of the curves at about 18 months or so, and improved overall survival with the addition of flutamide to Lupron. And again, remember, this was daily. Next slide. But the challenge with this, and David alluded to, there was a bunch of issues with regards to these as we look back on it. And I remember in at the beginning of all this, when we were using the LHRH agonists, my colleagues and I began patients on LHRH agonists, and we had several patients who acutely flared and died. And it led to a review that I think we published in Journal of Urology. We looked at what happened in other series, and there were 765 patients. 10%, almost 11% had a disease flare, an acute disease flare that was watched at the time. We didn't know what we know now. There's a lot of stuff that obviously we've learned over time. And there were 15 patients who acutely died during disease flare. And you kind of wonder yourself whether or not there was a greater number that was not recognized. Next slide. Because a lot of these folks really presented almost at end of life. It was a very different situation before the advent of PSA testing. And you would see this, as you see here is a graphic of the disease flare that can be very acute. But then with the daily LHRHs, you could get acute flares that we really weren't fully cognizant of during the initial administration. Next slide. And so the fundamental question, could it be these microflares that were involved? What would happen if a patient missed an injection and then caught up, if you will, and had another flare on top of that? And really, could it be the 4 to 8 weeks of testosterone surge that was effectively blocked with the flutamide that really rendered a less than adequate, which would be an LHRH alone, less than adequate, rather than flutamide truly being superior? And so Dr. McLeod and this group of iconic leaders decided that let's test the hypothesis in something that doesn't have a flare, which is orchiectomy. And that led to SWOG 8894, which has a bunch of other monikers in the other cooperative groups. Next slide. And so there he is again. You know, you can, over the years, we could all look back on all of these papers that were really pivotal in the management of prostate cancer and a bunch of other diseases. And there would be Dr. McLeod's name as a leader of this. And I have to point out to you, as you see the flag in the Mikey Stadium in New York, a military leader, which was very important, which I'll come to in a moment. Next slide. And I just point out to you that this is a very different group of patients than we see today. You can see the mean PSA was 600 and was about 700 or so. So a very different group of patients rather than the hormone naive patients that we see of today. These were patients it would break your heart if you're attending as a resident or as a junior faculty to go back to those days when about a quarter of all the prostatectomies that we did, we'd find positive nodes. It was a very different time. Next slide. So very advanced disease, but what did we find? Again, this is the backdrop of orchiectomy. Really no difference. No difference in overall survival with these patients. Next slide. And if you stratified by extensive or minimal disease, you see maybe a little bit of signal with the minimal disease. You kind of wonder what would happen, which we kind of see today, as Dr. Crawford pointed on, what might happen if you move the clock up earlier. But certainly in the presence of extensive disease at that time, which was really catastrophic disease by today's standards, no difference. Next slide. And here's the progression-free survival, really the curves on top of each other. Next slide. So what has been his impact in all of this? And you know, you have a whole bunch of people coming to give presentations about this really amazing individual. We take the knowledge of how to interpret PSA, how to use androgen deprivation therapy, and how to manage patients with prostate cancer for granted. We really didn't know very much. And, you know, today, a first-year resident, it's like it's part of, even the intern knows how to manage it. And it was David's continued efforts along this that made it possible. And as others have said along the way, is that his fingerprints are all over this. And we take it for granted, and we really shouldn't. Next slide. Two other really important legacies. He mentored a lot of people, and this has been brought up earlier. He cared very much about the residents, his residents. Sometimes at the expense of residents from other training programs, but really all the military residents were his and his faculty members. He loved every one of them, mentored them, and gave his time and effort, and he'd make phone calls for people as well. Launched the number of careers for individuals who've gone out and further changed the standard of care. And you've heard from many of those, not just for prostate cancer, but other disease processes. I mean, there are pediatric urologists that he mentored that are changing the standard of care for pediatric urology. He was also the catalyst for a legacy of academic and clinical excellence in the Department of Defense. And I use the military analogy that he walked point for all of us. It was a really tough path. And having been at the military academy towards the tail end of the Vietnam War, which he participated in on the ground in harm's way, leading troops in that location and caring for others, you don't really realize how bad it was to be in the military at that time. In the Veterans Day parade, or maybe it was Memorial Day, I don't remember what it was, marching as a cadet on Fifth Avenue in New York, we were taught how to protect the flag. It was a bad time. And military urology had the stigma of Vietnam War. And Dr. McLeod was out front from an academic standpoint, from a leadership standpoint, caring for patients standpoint, in front of the AUA and other organizations. We really have to be grateful for what he did, because he helped create military urology, the bona fide academic medicine of the military. We should never take that for granted. We will always remember that. For that, we're very grateful. And I have a brief anecdote. We all have anecdotes. I could tell you a few that probably it's being taped, so I'm not going to. But I'll never forget. I think it was Cash Mustafi and his wife's anniversary, or his or her birthday or whatever. And we were in Paris for it was a consensus conference of some sort. And of course, Dr. McLeod was one of the leaders of all of this, and I'm just kind of a junior guy. And Dr. Mustafi, everyone loved and adored. We could tell you more stories about that, and Isabel would be far better at it. But I'll never forget that Dr. McLeod and I decided that we were going to take our dress blues to this really magnificent experience. And it was held in a palace. I just remember it was some kind of a palatial estate in the outskirts of Paris. And we stayed too late. There was like a symphony playing and lots of food and a little bit of adult beverages. And we're wearing our mess dresses for all of this, not just the blues, but the cutaways and the ruffly shirt and the bow ties. We're kind of standing out, but it was a big occasion. And David led the way and said, "It's okay, we're going to do this." Well, we stayed until everyone had left, and we put Cash in a cab. And then we realized no more cabs. And one of my favorite memories of all time was walking the entirety of the Champs-Elysees with Dr. McLeod, 1:30 or 2 o'clock in the morning on a Saturday night, telling stories in a little bit of a fog, if you can imagine, after a couple of bottles of wine that were passed around and so forth. And him, just like he did for everyone else, arm around your shoulder. I'm just some junior nobody, and him caring very much about me at that time. And for that, I'll be always grateful. Thank you for having me.
Thank you very much, Dr. Thompson. Our next presenter is Dr. Kevin Rice. Dr. Rice trained under Dr. McLeod and served as a urologic oncologist here at Walter Reed and assistant director of CPDR. He's now associate professor at Indiana University. Dr. Rice.
All right.
Just get my screen up here, sorry. That doesn't look like it's gonna let me share. Can you guys just pull up my slides?
Of course, we'll pull these up now. You have your title slide up now.
Okay. All right. I'd like to thank the CPDR leadership and as well as USU leadership for inviting me to pay tribute to Dr. McLeod today. I feel like a puppy among all of the household names that have presented so far. So I'm honored and humbled, but I'm most humbled by being able to honor a man who means a lot to me. So the paper that I was asked to present was something that I did or I helped out with during my research year. And it was on at the time, a lot of CPDR's resources were directed towards the ETS-related gene or ERG. Next slide. So our paper was published in 2010, and it was looking at the ETS-related gene as detected by an mRNA probe using GenProbe technology from exfoliated prostatic epithelial cells. Next slide. So this was really an intersection of two previous achievements in the CPDR's catalog, the most impactful of which was a paper that's already been discussed several times today. And that's Dr. Petrovic's groundbreaking description of the overexpression of ETS-related gene in prostate cancer, and that was published in 2005. Next slide. The other study was a paper that was written by one of my co-residents, Eric Whitman, that using the same GenProbe technology, they were able to determine that the detection of mRNA from PCA3 in exfoliated cells in the urine actually had some prognostic significance. Next slide. So our study was really about addressing the question was, well, can we do the same thing with the Tempus-ERG fusion? Several investigators had demonstrated this recurrent fusion, including our own group at the time. And the most prevalent form of these fusions was the Tempus-2-ERG fusion. And at the time, it looked like this was, it was a wide range, but it could be seen in anywhere from 36 to 84% of cancers, depending on the patient population and what detecting technology was used. Next slide. So there had been some groundwork laid for our study in two smaller preceding studies. In 2006, Laxman et al. Used quantitative PCR to detect the Tempus-2-ERG fusion transcript in the urine of 19 men. The sensitivity in this group was 42%. In a larger study in 2007, Hessels et al. Were able to detect fusion transcripts in 108 patients, among 108 patients with RT-PCR. In this study, again, the sensitivity was somewhat low at 37%, but it was quite specific at 93%. Next slide. So our study goal was to evaluate, if we could use this GenProbe technology, which we already had some experience from in urine samples to determine if ERG could be used for either diagnostic or potentially even prognostic information. Next slide. So from September 2006 to March of 2008, all patients undergoing a standard trust-guided prostate biopsy, and we weren't doing MRI fusions at that time, obviously, they were included or offered inclusion in the study. They were excluded if they were on medications that would affect PSA, such as finasteride, and we collected urine from 269 patients. 32 patients couldn't be processed because of either insufficient urine or insufficient PSA levels within the urine, and we'll explain why that was an exclusion factor in a second. And that left us with 237 patients as our study group. Next slide. So the first part in the study was an attentive digital rectal exam, which was really standard DRE, except, with 3 sweeps across the prostate and a little bit more vigor to try and express some of the epithelial cells of the prostate. Next slide. Then the urine was collected and placed in a buffer. Next slide. We then sent the samples to GenProbe laboratories where the ERG and PSA mRNA were amplified and quantified. Next slide. We used this to delineate an ERG score, and you can see that the score was really just normalizing ERG to PSA. So that's why, as I said before, people that didn't have adequate PSA were excluded. Next slide. We then performed a standard 12-core transrectal ultrasound guided biopsy. Next slide. Then Dr. Susserhan looked at all of the biopsy samples. Next slide. And we correlated these samples with our ERG score. Next slide. So there's our standard table 1. In terms of notable findings, we had a 40% positive biopsy rate. As is usually the case with CPDR, we had a enriched African-American sample with 30% of the biopsies being performed in African-Americans. And you can see, just reflective of the time of the study, we had quite a bit of low-grade disease at 67%. Next slide. So in terms of the relationship to the ERG score with our clinical characteristics, you can see that the only thing that stands out there, next slide, is the biopsy result, which was that there was an association between a higher ERG score and a positive biopsy result. There was no association with stage or grade. Next slide. And then this study, or this slide, is really just showing the different biomarkers that we had at the time. So the ERG score is represented by the blue line. The CMP-PSA, which was the standard of care, still is the standard of care, is the purple line. You can see that those are pretty similar. The urine PCA3 score, which was what we had published on with Dr. Whitman's study, is in the green line. And then a red line is incorporating all of those findings together. And you can see at this point, and this again is in the ground floor of this technology, that wasn't particularly impressive, but we'll talk at the end of where this technology has come as a result of studies like this. This really was a blueprint for what was to come. Next slide. So although there was no difference in urine ERG score predicted by race alone, urine ERG score performed better in predicting prostate cancer in Caucasians with an area under the curve of 0.678 as compared to 0.425 in African Americans. It also performed well in patients with a lower PSA, or so less than or equal to 4, with an area under the curve of 0.067 as compared to 0.054 for patients with higher PSAs. Next slide. The most significant finding of this study was the predictive ability within a subgroup of patients, that is Caucasians with a PSA of less than 4. And the area under the curve in that subgroup, which was 62 patients, was 0.802. In this same group for African Americans, it was 0.66. Next slide. So urine ERG using the GenProbe technology predicted malignancy in the prostate biopsy, and with an area under the curve that was similar to what our standard of care was. It performed particularly well in a specific subgroup as described. But unfortunately, we didn't, at least at this point, ERG alone did not help us prognosticate in a way that we hoped it would. And so at that time, we had suggested that future research should be directed at, seeing if this ERG is, maybe it's a protective prognostic marker we thought potentially at the time, and with this turned out to be the direction that the field would go, using urine ERG as a component of a multi-biomarker panel. Next slide. Next slide. And so these are just, if I could go through dozens and dozens of paper, but these are several recent higher impact studies that have come out, and all of these use ERG as a component of their panel. So this was a urine-based exosomal gene expression test that was able to stratify high-grade prostate cancer in men in prior negative biopsy, undergoing a repeat biopsy. So this is the ERG has now, with additional research, they are able to come up with some prognostic significance. Next slide. And again, an echo of our combining our two studies, a PCA3 and TEMPRAS-ERG urinary biomarkers in predicting patients that would progress on this large active surveillance cohort on the West Coast. Next slide. This, I believe, just came out in this month's Journal of Urology, which is called the My Prostate Score Test, rule out clinically significant prostate cancer. And I encourage anyone who has not read this to take a look at it, because it really does build on what CPDR has been doing for years. And it's by Dr. Shanayan, who's I think an occasional collaborator and someone who does a lot of the same research at the University of Michigan that we have been doing at CPDR. Next slide. And then this was a pretty high impact study in JAMA Oncology that demonstrated the association between combined TEMPRAS-2 and PCA RNA urinary testing, just like we were doing, and determining using these RNA transcripts to determine aggressive prostate cancer. So all this is to say that I was just the research resident that was given a project that had been thought up by Dr. McLeod and his colleagues. But it shows that how ahead of the curve the Dr. McLeod, CPDR, and all of my mentors over there were. That, they saw 10, 15 years into the future where the field was going, and they should really be commended for that. And I know they continue to do that to this day. Next slide. So with regard to this paper, I'd like to acknowledge the CPDR leadership and my mentors who are listed there. And then next slide. Next slide. So I'd also like to take a minute to talk about Dr. McLeod. You think about things in your life that, how fate just leads you somewhere that determines the trajectory of the rest of your life. And, for me, one of those things was, happening to be able to get into Georgetown to go to med school and meeting who would become my current wife. But a close second to that was, joining HPSP and then being lucky enough to train at Walter Reed and to learn from so many things about life from a true mentor. And when I think about Dr. McLeod, I think about four things. The first thing that comes to mind with him is humor. And it's not because it's the most important thing, it's just because that's the first thing that comes up whenever you meet someone who also knows Dr. McLeod. He is perhaps the funniest man that I've ever met. And he also wove humor into everything that he did, and with great effect in some tough situations in medicine. I remember when I was an intern, we went into a retired colonel who had metastatic prostate cancer and was pretty miserable because of his symptoms and had been pretty ornery with the staff and everyone. And he was there because he had to go back for, he had hematuria. And so we came in first thing in the morning, the guy had just been served breakfast and he's yelling at the nurses, and because they were trying not to feed him because Dr. McLeod had just decided to take him back to the operating room. And so Dr. McLeod walked in with his chief resident, Tom Novak, and the chief resident was always his aide de camp. So they walk in together and he says, you can't eat that. We're going to take you back to the operating room. Right? And the guy says, the hell I am. I'm going to eat this right now. And Dr. McLeod said, no, you're not. And he took the plate out from in front of the patient and he started eating the food in front of him. And for the first time in that guy's hospital admission, he started laughing hysterically. So he knew how to use his brilliant wit to help his patients out, and he did it all the time. Beyond his humor, also his leadership is something that has been talked about a lot today, and it should be, because McLeod was someone that you can't push rope, they say. You have to, a leader needs to be able to never look back to make sure people are following him into battle. And that was, McLeod never had to look back. Any one of us would follow him anywhere. And that was the type of trust that we had in him. And that was the trust that he earned. He also used that leadership to prove, and it's showcased today by the people that came from all over the country and the world to pay tribute to him, He was able to inspire or the confidence for these big academic centers to collaborate with Walter Reed Uniformed Service University and military medicine, so that we could contribute our patients, our resources, our physicians, our nurses to the furtherment of the field and the improvement in care of patients. And in return, our patients would receive cutting edge care for that. And that's only through Dr. McLeod's leadership. And I'm here at Indiana University. I meet people all the time whose lives he touched. The guy who did my VA physical like the bowels of the VA hospital here knew Dr. McLeod, and he couldn't stop talking about him. He has touched more lives than any of us will ever know. His dedication to patients is the most important thing that he's taught any of us. And you can spot a former McLeod resident from how they treat their patients. When you first work with a guy of his stature, as had been mentioned earlier today, you think that, you're going to go take care of the senators and the flag officers with him, and everything else will kind of fall to the rank and file urologist. But it wasn't that. From the second I met him, it didn't matter if it was a household name who'd be on Meet the Press on Sunday, or if it was some 20-year-old kid who had just enlisted. McLeod would go to war for any one of his patients, and he did it every day. And I mean, hell hath no fury like him if he thought that someone was trying to deprive one of his patients of anything or any resource that they deserved. And then the last thing is friendship. He was a great friend, and I miss him terribly. Thank you.
Thank you very much, Dr. Rice. Our final presenter for the morning is Dr. Oliver Sartor. Dr. Sartor has worked with Dr. McLeod in the CPDR, both in his role at NCI and now as a professor of medicine and medical director of the Tulane Cancer Center. Dr. Sartor.
Thank you very much for the opportunity to be here today. And I'm about to share my screen. I'm going to try to make sure that everybody can see it properly. Let's see, let me get my slideshow. And can you guys see that okay?
We see it clearly.
Good. Well, damn, I'm having a hard time getting started. Dave is a great guy. I remember him in a lot of different ways. I wanted to find a picture, and I found this one on the internet, and I kind of liked it because that's him with his tough face on. But anybody who knew Dave knew that he was both tough as nails and he was soft as a little kitty cat. He had real compassion for his friends, his coworkers, his family, and his patients. And, I appreciate what was said a few moments ago. His passion for his patients was legendary. He wanted the best for every single one of his patients. Now, I thought I would throw this up. I was kind of trolling around on my computer to find out what sort of slides I might have that related to Dave. And Dave and I had a lot of collaborations. I'm trying to remember the first one. I think it was in 1993. And Dave, of course, was a very distinguished urologist with worldwide recognition. And I was pretty much of an unknown guy back in 1993. Nobody knew who I was. And what we did is we would tag team. If you want to know the truth, Dave would bring in the audience because nobody's going to come and listen to me. And then I was talking about some of the systemic therapies that I was starting to explore. And Dave and I would go back and forth, and it might even have been on a riverboat on the Mississippi River that we gave our first talk together. We gave many, many talks together over the years. This was a conference we did down in the Virgin Islands. And he and I co-chaired this conference and had some great people like Dan Petrolak and Alan Parton, Carlos Perez, who's the chairman of radiation at Washington University. Alan Parton, of course, everybody knows, is the chairman of urology at Johns Hopkins now. Dan Petrolak at Yale, and very distinguished. And we had fantastic faculty that we put together. Dave and I would tag team on getting the best people in the field to come down and join us and put together a syllabus and a series of talks. We really had a lot of fun. And Dave, of course, was great to work with. I went back and I found this is actually from Dave McLeod's lecture that he gave in 2005. This is his slide. I found it on my computer somewhere in the dregs. And he was talking about surgery, the state of the art. And of course, people would come from all over the world to listen to him. And I kind of like this slide because this is his slide. And he's saying, now, which is better? Do you want to get the nuclear option and get nuked, or do you want to have our precise surgeons? Well, it was interesting because some years later, I got a call from Dave, and he said, Oliver, I have prostate cancer. I said, damn, Dave, what are you going to do? And he says, well, I'm going to get radiation. I said, radiation, that's interesting. Tell me why. And Dave said, well, you know, the radiation suite is right down next to the operating room, so I can just go get my radiation done and then just go straight to the operating room. They just make it easy. So I said, go for it, Dave. But it was really interesting. It is personal experiences. He chose the nuclear option. I always laughed about that. He made me laugh a lot, by the way. He had a fabulous sense of humor, as we just heard. I went back and tried to find our first paper that we did together, and it was kind of interesting because even though we did a fair number of talks together and conferences together, I think it was about 2001 that we had the first manuscript that I could dredge up. Probably had some abstracts before then. A lot of people don't know what caprimab pinditide is. Why would they? For those who might be wondering, it is a PSMA-directed antibody. Well, today, PSMA imaging is all the world can talk about. But this was the first PSMA-directed imaging, and Dave and I were writing about the imaging that we thought was important. It was a hard image, though. The antibody-based imaging was not so great, and there were some issues with it. And I think one of the reasons people were so excited about the PSMA testing and PSMA PET that you are going to be seeing FDA approved this summer was so much better now than it was then. But interestingly, Dave and I were writing about PSMA 20 years ago. This was our last paper together, which was 2020. See, Dave is the fourth author in this manuscript. I was honored to be able to be the first author on this one. And it actually started with a presentation that Dave gave at the AUA in 2012. And I went back and I checked the date just to make sure I'm accurate. Dave had published a tiny little abstract with just a few patients suggesting that African Americans may respond particularly well to this form of immunotherapy, the sickle cell T immunotherapy, otherwise known as Provenge. And he published that observation back in 2012, and he and I talked about it. I said, gosh, Dave, if that's true, it's important. I said, it's just so damn small. I mean, we have to pull together a larger experience. Well, I hate to say, but it took us about 8 more years from 2012 to 2020 to pull together that experience and get it published. But Dave was the one who gave the idea for this paper. And we put together a registry and worked on it hard. There are a lot of people who worked on it. But this became a large and important series. And you can see authors here from Duke, and of course, Dave McLeod and Nick Vogelsang now in Las Vegas, Phil Kantoff from Harvard, Dave Pinson from Vanderbilt, Eric Small from San Francisco, Neil Shore, everybody knows Neil, et cetera, Paul Shellhammer. And when you put all this together, it's a large team effort. But Dave was the one who gave us the idea and who led it. And I'm thankful to him for that insight. You know, there are a lot of ways I could say thank you. His real devotion was to these guys. Loved the Army, loved his patients, and always did his best for them. Thank you, Dave, for all you did. Thank you very much.
On behalf of the committee that worked on this morning's scientific presentations, Dr. Doby, Dr. Jed Mall, Dr. Petrovics, thank you to all the speakers, those in person, those from around the globe who joined in virtually today. I hope this gave you a small snapshot. It was hard for the committee to choose the 12 most seminal papers. It's New England Journal here, New England Journal there, New England Journal. But your husband, father, grandfather, friend, as you heard, his legacy is almost unparalleled in the history of science and certainly urology. For the rest of the day, we will resume at 1 p.m. Eastern Time with additional tributes and dignitaries giving remarks. For those of you who are here in the audience, we invite you. There's a cafeteria just down the breezeway here, which is open if you'd like to take a break for the lunch hour. And we'll look forward to seeing you back here at 1 p.m. Thank you.
Good afternoon, ladies and gentlemen. Could you please grab your seats so we can get on time? Because if not, Sharon Holland's going to give me a hard time. Hey, Joe, it's good to see you. And Tom, you just give me a sign. Are we up? We good? You have good audio? Okay, we're good. Thank you, everyone, for being here today and for joining us as we continue this celebration of Dr. McLeod's academic and his scientific achievements, and also his incredible life. And I think that we had an opportunity. First things first, I do want to, again, ma'am, recognize you and the family that are here. The McLeod family with Claudia, son David, Kevin McLeod, and Yvette and Ann Saylor, Lisa Wild, and Jimmy Gearhart. Did I miss anyone? I think we can have everyone. Thanks so much, really, for being here and spending the time with us. It means a lot to have you here and carving out your time out of your schedules to be here to recognize Dr. McLeod, your loved one, who's loved by many here today. Welcome, everyone. You know, I think that I want to recognize several of our distinguished guests who've joined us here in person, and there's many others who are online listening in today. Throughout the morning, they've been here, and they'll continue through the afternoon. But first off, we have United States Congressman Neil Dunn and Mrs. Dunn. Sir, ma'am, thank you so much for joining us here today. Lieutenant General Ron Place, I don't think he made it over in person. He sent me a note that I think he's just going to tune in today. But he's the Director of Defense Health Agency. Retired Marine Corps Lieutenant General Earl Hailston. Retired Air Force Major General William Mormon, Senior Judge with the U.S. Court of Appeals for Veterans Claims. Retired Major General and friend of mine, Joe Caravallo, Jr., who's the President and CEO of the Henry M. Jackson Foundation, of course. And I'm not going to skip, hopefully, anyone else, but there's so many other folks that are, like I said, if you're not here in person, you're online today listening in and taking the time. So thank you all for sharing this time with us. Now, if you joined us this morning, you had an opportunity through the academic symposium. You heard about Dr. McLeod, the surgeon, the scientist, the teacher, the mentor. There were a number of presentations by his former colleagues, really literally throughout the world. And it was a very good program, and thank you for that. Dr. McLeod had a profound effect on so many generations of military urologists and other military healthcare providers, but he also impacted many other providers and professionals, and especially countless patients that he cared for over his many years here. And that's our priority always. So this afternoon, you're going to hear a little bit more about Dr. McLeod, mainly Dave McLeod, the father, the husband, the friend, and the mentor to so many. I'd also add that he was a fierce advocate for military medicine and for this university. Every time that I saw Dr. McLeod, he would always ask me how things were going. Well, it wasn't so much to ask, he was demanding to know how things were going here because he was always so interested in that. And, you know, he's a force of nature, so I found myself opening up. He had a true passion for this school, and it was obvious to everyone around him, and we appreciate that so much. So I want to thank you all and thank our next speaker, Dr. Craig Shriver, who's the director of the Murtha Cancer Center at Walter Reed and the Murtha Cancer Research Program here at USU. Where are you, Craig? And really, I think that Craig is the epitome of the military surgeon, the researcher, the clinician, the very type of model doctor that Dr. McLeod aspired to develop. You're it. Craig, thanks so much, and to your entire team and all your efforts you put together to make this afternoon, this day, a memorable event for everyone who's in attendance here today. So come on up. Thank you. I'll get out of your way here. I'll chicken wing you here. How's that?
Thank you, President Thomas, and thank you for your unparalleled support of everything that we do, of this event, and your incredible leadership of this university. Greetings. I am Craig Shriver, Professor of Surgery at Uniformed Services University and Director of the Murtha Cancer Center Research Program here at USU. A verse from the Sermon on the Mount about bereavement. Blessed are those who mourn, for they shall be comforted. A verse from the Talmud, the deeper the sorrow, the less tongue it hath. We heard this morning, as President Thomas mentioned, about what a success David McLeod was. Christopher Morley, who was a famous 20th century American journalist and poet, wrote this about success. There is only one success: to be able to spend your life in your own way. Today we honor a man who definitely lived life his own way. Can you think of a man with a fuller, more complete life well lived than David Gwynn McLeod? Can you think of all the things that David McLeod was? A husband, a father, a grandfather, a Marine, a soldier, a doctor, a lawyer, an educator, a professor, a scientist, a discoverer, an inventor, a comedian, a friend, a blessing. All of us in our own way think of Dave McLeod in his own way. For his life fills us in its own special way, and the void that his passing leaves in us will not be filled by anyone or anything else, nor should it. As hard as it is, that void in us, in our lives, is our permanent reminder of the special man that we were all privileged to know during his time here. When considering what common bond unites us in our feelings towards Dave McLeod, I turn to the great English author C.S. Lewis, professor of Cambridge and Oxford, and author of the Chronicles of Narnia and other great works, who wrote in his book, The Four Loves, about the different types of human love and how they are expressed. What Dave McLeod engendered in all of us can best be described by C.S. Lewis as affection. For C.S. Lewis wrote, quote, "Affection is the humblest love. It gives itself no airs. People can be proud of being in love or even of friendship, but affection is modest, even furtive. Affection usually needs absence or bereavement to set us praising those to whom affection binds us. We take them for granted, and this taking for granted, which is an outrage in other types of love, is here right and proper. It fits the comfortable, quiet nature of the feeling. Affection would not be affection if it was loudly and frequently expressed. Affection almost sinks or slips through our lives until the end." Today we remember and honor David Gwynn McLeod, who, in living life his own way, touched us in our own way, and who earned the affection that binds us all together in our mourning and memorial of him. Following now, and I called his son this week to get permission to do what we're going to do now. In December 2012, the Murtha Cancer Center Research Program and the Murtha Cancer Center were designated as the only Department of Defense Center of Excellence for Cancer Care. That was December 2012. In June 2013, we held our first Murtha Cancer Summit. And for that summit, I invited David McLeod to talk about the journey of the CPDR and about his journey and about the CPDR in general. What follows is a 10-minute video of David McLeod in June 2013 at the Murtha Summit. John?
These are some of the associations we have with the National Cancer Institute. BRCA1, BRCA2 mutations, novel markers, investigation of immune infiltrating cells in prostate cancer, and early detection research network. And this again is this continuum. This was Dr. Mustafi, a world-renowned pathologist who is now deceased, who helped us immensely in the program. We have a basic science program out in Rockville, Maryland, that a lot of you have seen. We leased the land from a landlord who has been very nice to us, but I think we've been nice to him too. We update the property. But in closing, I'd just like to thank everybody in this room, my colleagues, and thank everyone. Mary McGarvey is over there. I might single her out. She is the one that, Mary. She's a person that takes care of it. When patients are newly diagnosed with prostate cancer, we bring them in with our radiation oncologists, and we go through the treatment. Now you have active surveillance versus watchful waiting in different ways. And prostate cancer is a challenge, like all malignancies. But I feel very fortunate in having such a team and being a member of your team. So with that, I will sit down. Thank you very much.
Thank you for allowing us to show that video. To our friends online, we understand there was an audio problem. We will post that video on the USU YouTube channel for you to view later. It's my privilege now to invite up to the podium Congressman Neil Dunn from obviously the US Congress. And more importantly, he was my chief resident when I was an intern. Sir, those charts I owe you are out in my car. I'll give them to you at the end of the day.
So Craig dated me a little bit there by pointing out that I was chief resident when he was an intern. But that's true. He was a good intern too. I know that surprises everybody. It's really great to see old friends again. I'm of course sorry for the reason we are gathered here today. And I want to express my sincere condolences to all the McLeod family. I remember Claudia very, very well, and I've enjoyed getting to know David Jr., Colonel McLeod as well. I hope we'll have a chance to talk some more today about all that. So David, was a really, really special person and a lot of accomplishments, a lot of character. And as Craig alluded to, he was a lot of fun. He did manage to keep things moving all the time, and he had a lot of vision. I'm sure that he's a large reason why Colonel McLeod Jr. and the other siblings can look back on their own lives and say they had good influences. He certainly was very, very influential in my life and many, many others. I mean, so he was a leader himself, but he also brought along a lot of other leaders and a lot of surgeons and a lot of other people that weren't surgeons. So again, as Craig alluded to, he was also a Marine and a soldier. We did tours in Vietnam with both the Marines and the Army, and that side of his character was never really very far away. So he was real military, no question about it. And I want to share an anecdote from those times when I worked for him at Walter Reed. I had done an extended TDY in New Zealand with one of our brigades, and as soldiers will do in these situations, I traded out pieces of my uniform for pieces of their uniform. And so we had a grand rounds when I got back to Walter Reed one, and it was held here at Bethesda. And David, wants to a little bit of that Army-Navy thing going on. He asked us all to wear he told us all to wear our uniforms that day. And I showed up with our uniform, but the sweater was a Kiwi Army sweater. And very, very similar to our sweater, with a notable difference. Instead of having a pair of captain's bars on it, it had 3 royal pips. And I won't have, John probably remembers this story. I won't make a long story short, that didn't pass muster. Uh, so I never did that again. But he was pretty strack in his own way. I mean, great officer, great military man, as well as a great surgeon and doctor. I remember the dream of the Prostate Disease Center. It did not come to fruition while I was still working with him, but it did later, very shortly thereafter. And I know Judd was involved with it for a long time as well, and very proud of that. It influenced his interest in prostate disease, influenced me throughout my career. I went on to spend the last 10 or 15 years of my career as focused on advanced prostate cancer, and that was the patient population that I spent a lot of time with, and with the Prostate Cancer Foundation there. So, and I think we made some great headway, but it was, again, that's a formative thing from David McLeod's mentorship. You know, it's hard to prepare. You cannot prepare for the loss of your father, your husband. And I know that no words that I have can ease any sense of loss that you have at this time. But I want to make note that I have felt with the loss of my own father. I could tell that when it was first fresh, you know, it was hard to breathe when you thought about him. But now, every time I think of him, it's a source of joy and pleasure and strength, because he filled us with a lot of, myself and my brother, with a lot of good memories and a lot of, I think, a certain amount of character. And I just know that that's going to be true for the McLeods as well. I mean, in time, this will be nothing but a pure pleasure to remember David, because he is admirable. He had accomplished so very much and done so much for so very many people. I did a tribute to him I want to give to Claudia, and this is, I read a eulogy for Colonel McLeod into the Congressional Record on the Well of Congress, and we had it framed, and I would like to present that to you, Claudia, if I can. She and I are, we don't mind.
I've never lost for words, but I've been lost for words. Thank you. Thank you all.
I just hope it'll remind you, and of course it'll be in the Congressional Record forever. What a great guy David was. God bless you.
Thank you.
Thank you.
Really appreciate
Thank you very much, Congressman Dunn. Our next speaker will be Dr. Judd Moll.
Thanks again for giving me the opportunity to be on the podium here. I'll get to my prepared remarks in a minute, but I do want to recognize all the speakers from this morning. What a moving morning with all the scientific presentations, and it was just wonderful. I've already gotten a bunch of emails from former residents and colleagues who, you know, have really expressed their gratitude for this event. So I would say many of our former resident colleagues from Walter Reed are listening in today or tuning in. It's always a hard act to follow Dr. Dunn, Congressman Dunn. Neil, I know Craig said that I didn't realize you were his intern. I was his junior resident, and again, I can't tell too many stories, but as I said before this began, we had some amazing times, and one thing I'll say about the chief was he really let us spread our wings, and we did so many cases, and you know, he would pop his head in the room, but we got through them. You know, I'm just honored and humbled to participate in this memorial celebration of the life of Colonel David G. McLeod. On behalf of Ellen and our entire family, we convey our deepest sympathy, but rejoice in the reflections of an amazing man. I want to recognize Claudia and David Jr. and the entire McLeod family. I just, you know, want to thank you for sharing Dr. McLeod with us for all these years. to help convey, what an incredible person he was. And we've heard so many amazing stories this morning. Mixed with the science was his humanity. But I just want to share a couple of brief stories. In 1984, when Colonel McLeod became chief of urology, and I know Neil and I remember that Dr. Stutzman had been the chief right before Dr. McLeod, and then the transition in 1984, when I was a junior resident, you were a year ahead of me, he became chief at Walter Reed, and I was serving as a urology clinic doctor and junior resident, and as all the military folks know, we were given a responsibility at a young age, and I was really green, and I'm not talking about Army green. I'll never forget, I told a patient and his wife that I was quite certain that he had prostate cancer based on my prostate exam. Now, this was in the era before PSA, and of course, then the biopsy returned as normal. It was a rock hard prostate, and I was inexperienced, and I, just used the C word when I shouldn't have. The wife really tore into me. She marched back to the chief's office to complain. And I was really upset. I remember going back to that room in the clinic, in the old urology clinic. I put my head on my desk and I bawled like a baby. I was just really upset. And I shouldn't admit that, but I did. I don't really even remember what Chief said to me later, but he was very reassuring. I just remember he didn't yell at me. And again, this illustrates early on his unwavering support, not only for me, but the entire team, and his ability to create a teaching moment using positive feedback, humor, and support, particularly humor. In 1991, my father-in-law, who's a proud World War II Navy veteran, was dealing with advanced prostate cancer. I mentioned this to Chief, who, as everyone can relate to, he sprang into action. And you can just picture him, getting right up out of his chair. And I'm not sure where he marched to, where he went to, but he sprang into action and facilitated my father-in-law's admission to Walter Reed. Then he worked with our longtime friend and colleague, and here today, Colonel Nancy Dawson, to get my father-in-law into a clinical trial with NCI and Walter Reed. Chief didn't have to do that. He really didn't. But he did it to support someone on his team, and as someone who had true compassion for his patients and for veterans. And this has been alluded to this morning multiple times, but as everyone in this room knows, he could get things done. He knew everybody at Walter Reed. He ran the show, and this was just one example. And to this day, our family is eternally grateful for this act of kindness and compassion and truly going way beyond the call of duty. Finally, the years between 1992 and 2004, when we worked together to help build the CPDR program, by far and away, they were the best professional years of my life. And much credit goes to Dr. McLeod. And as everyone this morning and this afternoon has alluded to, he was an amazing leader. But I'll give you one more amusing story. And I know some of the general officers in the audience may be able to appreciate this. In the early years, we were summoned to Fort Detrick on a number of occasions to give the commanding general briefings on the CPDR's program's progress. And this is off script, but I can't remember who the general was, but they said he wants a lap briefing. And I wasn't, of course, I hadn't really grown up in the military. I wasn't sure what that was, but basically no slides, and you had to prepare like the papers, and you had to have your papers on your lap, but not look at your papers. And I remember Dr. McLeod briefing me on what that was. Anyway, I was responsible for giving the briefing, and I was the junior officer, and it was really pretty nerve-wracking, but we got through it. But one time, Chief drove and when we were leaving the base, he went the wrong way. He went north. And we ended up in Gettysburg and spent, I don't know, the next how many hours shopping for Civil War historical prints. And much to Ellen's chagrin, this led to a period of years when boys will be boys with their toys. I really couldn't keep up, but I tried. And now I still have those prints. I'm not sure, you know, and then they're a cherished part of our life. But, you know, I want to face it that, you know, I was really under his influence. I really was. From military prints to Oak Island to his stock tips, and most importantly to urology and urologic oncology. For the better part of my adult life, he was really like a father to me, and I loved him dearly. On behalf of his many residents, students, researchers, and fellow soldiers, I thank him for his myriad contributions and his leadership of Army urology and military medicine for the better part of several generations. Thank you again for allowing me the opportunity to speak. Thank you very much.
Thank you very much, Dr. Mull. Our next presenter will be Dr. Harold Fraser.
Well, good afternoon. It's great to see everybody. A lot of great, wonderful old friends. Dr. Thomas, thank you for putting this all together. All the people that coordinated it. Congressman, we met very briefly when you were a chief resident. I was an intern, but I was in the canoe club. Remember that very distinctly. So, but it's really great to see everybody. I am grateful for the efforts for this glorious event. Colonel McLeod was a gem. And he really, truly deserves this. He was an amazing researcher, a gifted surgeon, a true leader. And I count on my one hand the number of individuals who've had a profound impact on my life, and Colonel McLeod is among them. For a lot of reasons. I didn't train under him. I was not a resident here. But I learned more from him than almost anyone that I learned in my early career within urology. I remember my first Kimbrough urologic seminar back in 1987 where I presented. It was held at the LaFawn Plaza in Washington, D.C., and Colonel McLeod was the course director. I was kind of intimidated by him, actually, because he was a big cheese and I was just his newbie. And they were playing the color, they brought the colors, they played the national anthem, and then the event started. It was a dreary Monday morning. I was the first speaker to present my research. I was scared. I didn't know what to do. I stumbled walking up to the podium. He crossed my path as I was walking up to the front. And he said, good luck. And he said, knock him dead. First time I've ever met Colonel McLeod personally. I was stunned because I had held him in such high esteem. I had no idea that he even knew I existed at that moment. I presented my paper. It was on ballistic trauma to kidneys and sutureless repairs. And it was kind of a landmark article in many ways. But the reality is that I didn't think it went very well. You know, I didn't feel great about it. I walked away. I certainly didn't knock him dead, right? And as I went back to my seat. I stumbled back to my seat. I sat down. And as the session finished, he came running over to me and he said, that was great. He said, this is going to be a landmark paper. I said, and I'm just sitting there going, oh my goodness, this guy really does know me. So I was stunned by this, and he paid attention to me that little old me, I just cherished that. You know, there was a moment in my life where it just kind of picked me up and made me feel very special. From that day forward, I always sought him out at the Washington Urologic Society, at the Kimbrough, at the AUA, and he really helped me understand a lot of the nuances of urology throughout the year. But also, he helped me introduce me to the urologic family, and it really is a family. So I really want to emphasize the fact that David McLeod was a mentor, a wonderful mentor. While I was training at Bethesda, I was Navy, I was Canoe Club, I was one of the bad guys in Dave's mind. We would gather every third Saturday morning, if you all remember. Saturday was just another working day. and we would have the Navy Army Pilogram Conference, right? Or Army Navy, whatever. And this was one time when the Navy and Army residents would present interesting and challenging cases, sometimes confounding cases, to try to put each other on the spot, right? I see a lot of nodding heads here. You all remember what I'm talking about. Colonel McLeod used to love to challenge us, demanding differentials and talking about clinical care. Well, what do you think? Dr. Mao, what do you think? You know, Dr. Dunn, what do you think? And I remember it to be an intimidating experience, but I always strove to meet his expectations, you know, and he always expected excellence. He didn't expect perfection, but he expected excellence. He wanted you to do the very best. During my fellowship at Duke, I wrote more than a dozen papers. I presented at the AUA meeting, and David would always search me out. He'd come talk to me about my papers, what I'm doing. And I presented one particular paper during a plenary session that contained a lot of data looking at perineal and radical retropubic prostatectomy. It was a little controversial. The data tended to favor perineal. And I presented the paper, and well, two of our AUA stalwarts stood up. There was Dr. Patrick Walsh and Dr. Bill Catalona at the mics, and they proceeded to try to tear me apart. It was a very uncomfortable situation, needless to say. They were less than complimentary, but luckily I was prepared. I was ready for them, and I handled it well, and I actually received great feedback about it. But later in the morning, Colonel McLeod sought me out, and he went ahead and started tearing apart Dr. Walsh and Dr. Catalona, but with very saucy language, right? And I was really kind of chuckling about it, but it was touching to me. It really was touching for him to kind of make his way through the AUA to find me and to talk to me about it. But he clearly cared about his colleagues in military medicine. He was caring, and he was very compassionate, not only to his patients, but also to the workers that were around him, the colleagues. In my early years as a young attending, Dr. McLeod called me. He said, I want you to consult on a patient. Now, as many of you know, Dr. McLeod did a lot of prostate cancer surgery, and this was a prostate cancer patient. So I should have known it was a setup, right? Because why would he have reverted to me? I was a young buck. And what I found that the patient had a BMI of 45 or 50. He was very large. And nobody at Walter Reed wanted to operate on this guy. So he said, well, kind of pawn it off on the Navy guy, right? But you know, I was a little cocky. I wasn't wise enough to understand that maybe this wasn't a perfect case to tackle. I went ahead and took care of it. He said, Hal, it's a perfect case for a perineal prostatectomy. Yeah, right. Well, I was humbled. I'd done over 100 perineal prostatectomies at that point and felt pretty good about my skill set, but I was deeply humbled by the experience. A typical perineal took about 1.5 hours. This one took 6.5 hours. The guy developed rhabdomyolysis, which basically means that the muscle tissue broke down. He developed kidney failure. I felt awful. I was lower than an ant, right? Several days later, the patient's still in the hospital. Colonel McLeod called me into his office, said, hey, how you doing? As if he didn't already know. He knew what was going on. And I shared my sad saga. He listened attentively for several minutes without interruption, surrounded by the walls of all the pictures of all the colonels and the judges and the generals and the congressmen and senators, right? Little intimidating office to walk into as a young attending. And he sat me down and he heard my story. I had a pity party. He told me something that stuck with me throughout the rest of my career and continues to this day. If you never have complications, you're either not doing enough surgery or you're lying, right? Anyone who's in surgery knows what I'm talking about. And that really heartened me. It made me feel a little bit better. And then he went on to say, well, welcome to being an attending surgeon. This situation will pass, but in the meantime, take care of the patient, spend time with the patient, talk to the family, stay engaged, make sure that they know that you're there with them for the long haul. And I followed that advice throughout my entire career. The situation took all the energy that I could muster to go in and see the patient without running and screaming away because I felt so bad about what had happened. But ultimately, the patient's renal function returned to normal. He was discharged to home several weeks later. And you know something I learned from him is that the patient loved me, not because I did a great job in the operating room, but because I cared. because I spent time with him. And so Dr. McLeod was wise, and he imparted that on all of us. You know, not only was caring, but he was wise. Early in my time at Bethesda, Dr. Mile, who's here, and Sandy Peretzman, myself, actually pulled together a lot of military urologists, a tri-service group, very early before CPDR, and it ultimately became called USurge. And USurge was the foundation under which the CPDR originated. But at the time, we had all these great ideas, but we had no money. It was Colonel McLeod that not only secured the money, working with Senator Bob Dole, Ted Stevens, but it was also his energy, his vision that drove the project forward. And I really honor him for that. He wasn't a visionary, and CPDR occurred because of him. He was also a Tar Heel. He was disappointed that Dr. McLeod or Dr. Mile and myself went to Duke, right? Actually, Brant Thrasher, for that matter. We did fellowships at Duke. And he was always tickled and used to give me immense grief about that fact. And he used to call Duke puke. And how could anyone go to that place? He really had a great sense of humor, and it came out in the most unusual moments, as we all saw, even in his lecture that he was showing earlier. He radiated a joie de vivre, a joy of life. He really did, and I loved him for that. He served as the chairman for the 35th and the 43rd Annual Kimbrough Urologic Seminar. He mentored multiple residents who won the Kimbrough Memorial Research Award. He is the only member of the SGSU to be awarded the prestigious Tippy Stevenson Award. He got it twice. So he was a servant leader, and we can hear that in all these talks today, how he shared and he cared and he gave to people that worked with him. You can read his professional summary on that brochure. It's incredibly impressive. 50 years of education, teaching, research, mentoring, unbelievable. But he also had the respect of the generals. They listened to him. They didn't want to get on his bad side, right? And when he was on a mission, he had a focus. CPDR was his focus. Cancer was his focus. His military urology community was his focus. He got things done, and that's already been pointed out by everybody. So, an amazing man. Finally, most importantly, Colonel McLeod was devoted to Claudia, the love of his life. He was dedicated to his profession of urology, passionately loyal to the people that worked with him and trained with him, and he was a true and wonderful friend. We all will miss him. Thank you.
Thank you very much, Dr. Fraser. Our next speaker is Captain Eric Elster, the chairman of the Department of Surgery and newly appointed dean. Dr. Elster.
Thank you. It's an honor and a pleasure to be here to recognize a true visionary and leader. You know, in academic medicine, we talk about a triple threat or quadruple threat. And Dr. McLeod was all of that. As an educator, you've heard from his trainees, his residents who are here and have spoken, from Judd, Noah's here, Inger, Bennett Stackhouse, Joe Sturvis, and many others. As a researcher, he was par excellence. When Judd gave his talk this morning, he showed you the impact of the work that Dr. McLeod drove within prostate cancer. As a clinician, you heard how he is an outstanding clinician and really cared for his patients. And as a leader, he built and led the CPDR over years. But I'm going to add a fifth element to that mix, which very few ever achieve. And I would say that he was the conscience of military medicine. He was a truth teller. He always strived for excellence and would not tolerate any deviation from that course. He would vocally, either in person, correspondence, the old email system at Walter Reed Classic via CHCS, any remember, or even with a Sharpie on the wall, let leadership know what the right path forward was. And as Inger said this morning, they would listen. We can tell the Sharpie story later. I would not be standing here if it wasn't for the chief, for two reasons. I'm a transplant surgeon. When I trained as a transplant surgeon, one of the transplant surgeons that trained me was a guy named John Swanson, or Sidney John Swanson. Many of you know John as well. John became a transplant surgeon because he was doing a case with his fellow chief resident, and the chief walked in the room and said, "Who wants to be a transplant surgeon?" And John looked around and looked at Jay and said, "I'll do it." And John became a transplant surgeon, and John trained me. And that was because Dr. McLeod had the vision to see where Walter Reed needed to go, and that the program needed a transplant surgeon, and he needed to train someone to do that. Again, I wouldn't be there if it wasn't for that. I wouldn't be in this role that I'm faced with now without Dave, because he taught me to have integrity between words and deeds, and showed how visionary leadership can succeed in our complex system. As you heard a couple times, he was able to get things done. No matter the obstacle, no matter the challenge, he would figure out a way, and he would take that hill. You know, as I enter my new chapter as dean, I will consistently ask myself, what would Dave do? How would he tackle that challenge in front of us? How would he get there? And I will try to emulate that model. And I know he's looking down from above right now and smiling and very pleased with where we're going. Thank you all very much.
Thank you very much, Dr. Elser. Next, Lieutenant Colonel David McLeod, Jr.
Good afternoon, distinguished guests, ladies, gentlemen, and friends. First, I want to express my gratitude to the Uniformed Services University of the Health Sciences for creating the chair and for hosting the celebration of life in honor of my father, Colonel David G. McLeod. Also want to thank the Henry M. Jackson Foundation for creating the endowment. Lastly, I'd like to thank the indefatigable efforts of Dr. Shriver and Ms. Holland and those persons behind the scenes for bringing this all together. Although I was told I could have the floor for as long as I wanted, I'm going to keep my comments short, as we still have to hear from scores of people touched by my father in many ways. From his patient advocacy, visionary leadership, and unwavering support of Army medicine and prostate disease research, to his prankish sense of humor often displayed during annual prostate exams. Many of you experiencing the latter may recall the childhood injury to his middle finger, how it was bent over. Dr. McLeod spent more than 50 years caring for his patients, from the battlefields of Vietnam to the political minefields of Walter Reed National Military Medical Center. He was the most dedicated and tireless physician, caring mentor, selfless officer, military historian, and loving father I've ever known. I cannot ever recall he has taken a day of sick leave. And after hearing Dr. Thompson this morning discuss how he, as a surgeon oncologist, took radiation treatment, I now understand why. Between surgeries and consults, he received his radiation treatment to treat his own prostate cancer. So again, he could go back and forth to his patients. Later, he even underwent light therapy treatment for his skin cancer amid seeing to the care and treatment of others. He always went above and beyond the call of duty to see that those under his care received the very best Army medicine could offer. During the last few months of his life, they had continued to visit many of his colleagues and tried to remain engaged in furthering the urology program. My mother and I observed Dad's hands moving in the air in very distinct pattern while he was resting. And I believe it was Dr. Sesterhan and Dave Boss who visited, mentioned those are the surgeon's nods he was doing. All a testament to his lifelong surgeon who gave his life advancing medical care. Dad passed with my mother and me by his side 3 months ago yesterday. He'd be 85 tomorrow. And I thank Dr. Shriver and Dr. The president of USU, for arranging this ceremony to be today, as it so comports with his birthday and his passing. Thank you all again very much for taking time to celebrate his life today and continuing his legacy. It was often hard for us growing up with Dad working 12+ hours a day, taking calls over most every holiday, and always being on the phone. But seeing the results of his achievements and the lives he has touched has kept everything in perspective. I'm glad to have shared my father with many of you here, and I'm honored to call you all family as well. Again, thank you very much for taking time to celebrate his life today and continuing his legacy. We look forward to having Dad interred at Arlington National Cemetery with full military honors at a later date this year. Thank you again. Over to you, Colonel Shriver.
Thank you very much, sir. Finally, Dr. Shriver will come up for concluding remarks.
Thank you, sir. That was marvelous. Next, and with, again, gratitude to the McLeod family, Claudia, David, everybody, for supplying most of the photos, please enjoy this video tribute to David G. McLeod's life. This concludes this portion of the celebration. We'll reconvene at 2:15, so a little bit early, to start the open tributes. We have some refreshments out here for those in attendance, socially distanced cupcakes and coffee and water. Please enjoy, and we'll see you back here at 2:15. Thank you. Get started here momentarily. All right. All right, this next session is an opportunity that we gave for anybody who wanted to be included to give a 5-minute tribute to Dave McLeod. I think I did a quick adding up. By the end of today, we will have had close to 40 or more speakers, separate speakers, both in virtual and here in the room speaking. We wanted to give everybody a voice. So for the next couple of hours, emceed again by Commander Chestnut, our Center for Prostate Disease Research Director. We'll be doing the in-person tributes for the first half, and then we have a number of videos that were sent in from folks who couldn't make it. To kick off our tributes, however, I'd like to invite up to the podium the president of the Henry M. Jackson Foundation, Joseph Caravello.
Well, thank you very much. They say in the Army anyway, the two things that you shouldn't do, one is give a lieutenant a compass, and the other one is to give a general a microphone. So at high risk, I'll try my very best to keep things under 5 minutes, but that's on general's time. Claudia, it's nice to see you again, and David and Yvette, and then their families. I have spouses, Lisa, Yvette has Ann and Jimmy, and then there's Kevin. So thanks to everyone to be here today, and it was nice to have Congressman Dunn here. I'd worked with their group with that tribute, so it's so nice that you're able to have this tribute for your home. Just so you know, we also have a copy of that, and then we will frame it, and then we will present it at the CPDR next to Dave's picture, and that will be a nice testament for him. Now, I am a USIS grad, and so I did a lot of time at Walter Reed as a medical student. At that point, I didn't really know Dave McLeod, and it wasn't until I had done my internship and residency, had gone out a little bit, and then came back, and I wanted to do my fellowship at Walter Reed, which is the flagship of Army medicine. I was at Walter Reed. I think they call it Walter Reed Classic now. Back when Walter Reed, when men were steel and ships were wooden, and really a tough place to be, but very blue collar medicine. You just did what you need to do to take care of patients. I see Nancy here. A lot of big names at Walter Reed then. Wartowski in endocrinology. That's when I met some kind of up and coming all-stars. Craig Shriver, Judd Mall. It was really an incredible time. I was doing nuclear medicine at the time. And as you know, nuclear medicine is a lot of scans and a lot of renal scans, bone scans, things that involve urology. And that's how I got to know about Dave McLeod. He was one of these internationally renowned individuals and really imposing figure. He was known literally by everyone at Walter Reed. Walter Reed, very big organization. Everyone, and whether you're a surgeon, and I'm not a surgeon, so I just hope you know, it's very impressive to have a non-surgeon talk about a surgeon. And that's how much Dave meant to me. But when I say everyone knew him, we knew him, you knew him either as Dr. McLeod, Colonel McLeod, the chief, but to those of us who were kind of at the lower level, we knew him as the Baron of Walter Reed, that he ran that organization. In the early days, when we're just in electronic messaging, Dave made ample use of this distribution list of Walter Reed all. And whenever he was upset, which is daily probably, he would send these notes out, and it was kind of a almost kind of a flight of ideas and it was pages long of things that need to be corrected at Walter Reed, and he would name names, and it was quite quite intense. So much so that it would put the Unabomber's manifesto. It would look like a letter to the editor, you know, on an opinion page. And this was just a regular event. And it would be like watching a car crash in slow motion. You knew it was bad, but you couldn't avert your eyes, and so you would just read it, right? You knew that you weren't the target of it, so you just read how he would slam that general or what have you, and it was like, oh my, he didn't really say that kind of thing, and it was just nonstop, and that's how everyone knew about Dave McLeod. So I have a couple of stories about him that I would like to share, but as a nuclear medicine guy, I remember I said bone scans and renal scans. So they would call us to do morning report with them and go over the scans. And I got to tell you, that was nerve-wracking because I'm a nuclear medicine in resident. We're the ones that were told to do this. And it wasn't long before you realized the chief of urology knew more about the scans than you did, and that you couldn't fake your way through it. In fact, he had the nickname of Dr. X-Lax because he could scare the crap out of you. So a couple of the stories that just kind of emblematic of the kind of person that he was, and probably shouldn't be sharing this, but in his ward, in clinic area, there was a roach infestation problem. And you think, oh, not in the hospital, but certainly there was. He would always try the system at first to get it to work, and he couldn't get it corrected. He couldn't get the Walter Reed guys to correct it. So he ended up calling what's called CHIPM, where the public health folks that were up in near the Baltimore area, and he said, I need you to come here and do us an evaluation to find out why we have this public health hazard going on and conduct a study. So they dutifully came over and they did all that. They weren't sure really who called them to do that. But when they were done, as they would want to do, is they would report out. And they reported out to the commanding general. And that's when the commanding general realized, I didn't ask for you to come here to look for roaches in my section. And it came back around that Dave McLeod had done that kind of thing. And that's the kind of person that he was. It needs to be done, and so he got it done. He started CPDR in 1992. That started a very close relationship and partnership with HGF. We were in the spirit of advancing military medicine. We provided a lot of the staff that brought that together, working with Judd and the team going forward. We walked through a lot of good times, tough times with him, but from basic science research all the way up through advanced development, tech transfer, and the like, the big endowment associated with CPDR. So we ran that roller coaster doing the stock plunge in the 2008 timeframe, where we got daily calls from Dave McLeod and how our stocks were doing. I didn't realize he was a stock expert at the time, but he helped us through that period of time. We didn't take a beating on his endowments. There was a time where he needed the money. You heard him talk about the money to conduct research, and the monies were not forthcoming from the beloved USU. And he tried and didn't get it. So he went to his old bag of tricks, and he wrote a scathing email to the leadership at USU. And he CC'd Senator Stevens, and you've heard Senator Stevens' name before as one of the individuals that pulled this together and got it into the palm and what have you. And everyone knew that he knew every congressman and senator on the Hill, and it didn't take long to figure out how he was so close to everyone. I mean, it kind of made a lot of sense. As a cardiologist, I learned that you get to meet a lot of generals and senior folks as a cardiologist, but not as much as you would as a urologist. Anyway, so he sent this scathing letter, and all of a sudden, everyone was pull out the stops, and they, we had to get after it. And they came back to Dave and said, "We'll assure you that we'll get this money." And in no time flat, he got the money. Now, Dave is not one to let a good deal go without notice. So he came back on the net and he said publicly, well, that email that I sent you, and it had CC'd on Senator Stevens, did you notice that the name wasn't spelled exactly right? I just typed that name in there. It wasn't ever really CC'd to Senator Stevens, but you thought it was. And of course, everyone got a chuckle except for the Vice President for Resource Management. Wasn't too pleased with that. But that's the way he operated. I just want to close and say you don't happen upon someone like Dave McLeod, but for once in a lifetime, once in a generation. And if you know Dave, if you had the privilege and honor of knowing Dave McLeod, and I knew him from our time at HCF more than my time as a nuclear medicine fellow. He was a good man, good educator, good mentor, good scientist, good officer, good professor, good friend, and I know he was an even better husband, father, grandfather. I wish that he is sitting, I know that he's sitting with his Lord, with your Lord. We miss him dearly. And we will do at HCF, we will do everything we can in our power to help continue the legacy of CPDR in his spirit. And it will be forever tied to the name David McLeod. And it's one of those names, one of these kind of legends that will live on in Army medicine, in military medicine, and for really global health in the spirit of advancing medicine in prostate disease research. Thank you very much.
Thank you very much. Our next speaker is Dean Louis Pangaro.
Good afternoon, everyone. I'm Louis Pangaro, Professor of Medicine. I'm interim dean of the School of Medicine, and I asked to speak because Dave McLeod was a hero of mine since the 1980s, and not because I was one of his patients or because my wife, who was a prostate cancer research nurse, worked for him, and we admired Dave very much in those professional capacities. But it's a very simple theme, that the comfort of leadership is not as important as the success of the mission. And the themes that you've heard earlier today, that Dave got things done because he was a generation of which confidence as a military colonel was more important than caution. And Dave would speak truth to power. And as General Caravallo just said, when CHCS, the electronic medical system, came out at Walter Reed in the early 90s, things were going wrong all over the place. Dave was on the email with everyone in the institution copied, as Joe said. And the theme was very, very simple. This is wrong. This needs to be fixed. Feedback, honest feedback in a system is critical. What I learned as a major then, when I was still in uniform, is that the comfort of leadership is not your concern. That's their concern. Your concern is the success of the mission. You bring honest feedback to bear whenever, however you can. What a lesson for me as a young officer. I'm ever grateful to him. And internist, not like Joe, not surgeon. What a great man, what a great vision. An idea of leadership that was mission-oriented, not comfort-oriented. I'm forever grateful to him. Thank you very much for listening to me.
Thank you very much. I'd like to invite our next speaker, Dr. Albert Doby.
Thank you. It's an honor, but in my heart also it's some sadness because I kind of expected him to live forever. The way we interacted every day, including his last weeks. So since I'm in a basic science part of the CPDR, I will give a story which is completely independent, but different from that. And that is related to those two parachutes on the top of his decoration. So you can see in the brochure, there are two parachute medals on the top of his decoration. So I decided to kind of test the audience. I believe there are quite a few medical professionals, doctors in audience online, most probably hundreds. My question would be, how many of you completed parachute jumps? I bet there would be a few who made parachute jump. Then my next question would be, how many of you completed parachute jump in a war zone? I bet there would be not that many hands up for that. And the next question will be, how many of you completed parachute jumps 5 times in a war zone in Vietnam, actually? When we worked on his legend article, because he was selected to be legend in urology by the Canadian Journal of Urology, Dr. Gomella, Leonard Gomella, and Dr. Gabor Haas was the facilitator of this wonderful article. He came to my office and said, oh, where did we stop last time? Oh, I guess it was the parachute jump in Vietnam. I jumped with him in Vietnam 20 times because we went so many times back to that jumping. He was very proud of that. So, and I did ask him that, weren't you worried about going in a war zone? No. Weren't you worried about jumping, the parachute, 20% injury rate, those days? I don't know. And what was then you worried about? He said, I was worried about when I learned that Claudia picked up the Sunday newspaper on Sunday morning. And on the front page, it said, Dr. McLeod's son, David, in Vietnam, completed his 5th parachute jump and earned the parachute medals. So, and he said that was the point when his voice choked, and I think he was holding back tears because you were pregnant with Dave. It was in '66. And I think that when it sank to him, that next time you will see him, and you did in Hong Kong, you flew to Hong Kong to see him, what are you going to tell? So I need to say, Dr. McLeod was an extremely brave soldier. He was not scared of anybody and anything, but talking to Claudia. So one of these decoration and medal is, of course, the U.S. Parachute medal. The other is the Vietnamese parachute medal, because the South Vietnamese army also, honored him as a parachuter. Thinking back, and just as a closing, he was a platoon leader in Vietnam. So my first thought was that now he leads his platoon of good souls to triumph up there. Thank you.
Thank you very much. Our next speaker is Dr. Bennett Stackhouse.
Well, like everybody else, my heartfelt condolences and best thoughts only for the McLeod family, and my thanks to everybody that's already spoken ahead of me. I've made, I think, 3 good decisions in my life, and I'm about to make a 4th good decision. The first 3 were to marry my wife, to join the Army, and to come to Walter Reed Urology and work for Dave McLoud. And those are the top 3. And then the 4th is to not look at these notes, because in a moment of self-delusion, I thought I was going to say something original about Dr. McLoud, and that hadn't already been said before, much more eloquently by those people who've spoken before me. Instead, I want to make share a couple of quick stories, because those are the things that are touching me the most. And I feel the most kinship actually with Colonel McLeod in the front row. So I'm 2 years older than you, and my dad is 84 right now. And when I came to Walter Reed, the relationship that I had with Dr. McLeod was very much the relationship that I had with my dad. I came, and when I came as a resident, I had been a GMO for a few years and had studied urology a lot, and we had to take a big test, all of the trainees, the in-service examination. And the first year I took it, I had been studying for it for basically 4 years. And I got in the 90th percentile, and I thought, well, that's no surprise. I'm such a smart guy. And so with my usual hubris, I focused on other things. And the next year that I took it as a junior resident, as a 3rd year resident, 1st year of urology, I think I got in the like 9th percentile maybe, or 10th. And so Dr. McLeod would call you in his office to go over the scores. And when it came my turn, he called me in, and I was expecting the worst. He put the paper in front of me, and I saw a single digit number, and it may have been slightly higher than that. It may have been in the low 10s or something. I can't really recall, because I was just so dumbfounded and embarrassed and ashamed. And then I was ready to be chewed out. Dr. McLeod was a tough guy, right? He was a tough human. And he said, "Are we ever going to have to talk about this again?" And I said, no, sir, we are never going to have to talk about this again. And he said, "Yeah, you're right. We're not going to." And he was right, and I was right. And that's what you wanted to do. You wanted to make him proud. You wanted to model him, have his work ethic, go after things the way he did. That was his good parenting, tough side. And then the only other story that I can share is that I started my chief resident year coincident with the birth of my 3rd child, the birth of our 3rd child. And my daughter was born with a pretty critical heart defect. And they had to put her on prostaglandin to keep her ductus arteriosus open. And she was going to die if she didn't have a balloon valvuloplasty to open up her crummy little pulmonic valve that never really formed. And they couldn't do that here. So on day of life 1, she was medevac to another hospital, and my wife and I drove in the car. We couldn't be in the helicopter with her. And when I got there, I realized, my daughter's born on Friday, and now it's Saturday, and she's getting this procedure done, and I'm gonna have to leave my wife to make it back to work on Monday. And once again, being the self-delusional dummy that I am, I hesitated before I called Dr. McLeod to say, "Hey, sir, I'm in Delaware at DuPont Hospital for Sick Kids that none of us had ever heard of, and so wondering if you would consider letting me miss a few days next week." And he cut me off. He said, "What's going on with your daughter?" And then I had to tell him the whole story. And he said, "Well, I'll see you when she's well." And he didn't tell me how many days to take off. He said, "I'll see you when she's well." And I realized that, much like my dad, my real dad, I had sort of magnified and completely miscalculated. I'm not a very good judge of character. I'm a little too, spectrum disorder-ish. Makes me a good surgeon, but not particularly good at picking up on stuff. So anyway, it's a short way of saying that my wife and Claudia have bonded over that story for forever. And I will love Dave McLeod forever. And I will always want to make him proud, and I still do in some very weird way. He's been watching over me for the last 30 years of active duty and then the 6 months or 8 months since I retired. That a lot of my external locus of control is exactly what was said earlier by somebody smarter than me. What would Dave McLeod do? You know, what would I do to make him proud at this moment? So anyway, thank you very much for hearing my story, and thank you for sharing your grandfather, father, husband with all of us. We really appreciate it, and he continues to touch our lives.
Thank you. Our next speaker will be Colonel David Benedict.
Good afternoon. McLeod family, I want to extend my condolences to you all, and also my thanks for sharing your family member with me. I'll talk a little bit. First of all, I'm a psychiatrist. I'm not an oncologist. I'm not a surgeon. I'm not a urologist. I don't know much about cancer. But before you start drawing conclusions, I'm going to give you my perspective of Dr. McLeod as a patient. I think Dr. Elster said he's not standing up here. It wouldn't be if it weren't for Dr. McLeod, and that's the case with me as well. So it's a long story. I'll try to keep it short. It goes a little bit like this. I went to Walter Reed for my residency, and I was a medical student here. So before I ever met Dr. McLeod, obviously, like anybody else, I knew who he was. He was a force. He got things done. I mean, I remember reading those emails. If Walter Reed, you could hear his voice, is such a world-class institution, you know, why are the bathrooms on Ward 52 a disaster? And you know, those bathrooms would be fixed right afterwards. And, you know, why, you know, and to dear all, why are the fire alarms going off every 15 minutes? Oh, thank God the fire alarm's going to stop. You know, when he said something, it would happen. So, but I knew that kind of person, you know, could be a little intimidating. And so when I first actually met him, I was scared. I was scared because of who I thought he was, but also because I had recently learned that I had bladder cancer. This was another story. I was practicing for a PT test and woke up with blood in my urine, and come long and short of it was I had bladder cancer, and I found myself in his office just knowing that. And I was like, oh gosh, what's this guy going to be like? And he was reassuring and candid at the same time. And he said, look, I'll tell you, you know, bladder cancer, it's kind of a bad thing, but I don't know if you're a wimpy guy, but you got a wimpy cancer. We're going to cut this thing out of you. We'll have to watch you, but you're going to be okay. Something else is going to get you. That's a pretty reassuring comments when you're freaking out. And I, you know, I took those to heart, and sure enough, he was my surgeon, and he, true to form, he did cut that cancer out of me. I remember I wanted to be awake during it, because I'm a doctor, curious. And I remember the last thing I remember from the surgery itself was him saying, okay, you guys got to shut this guy up. He talks too much. He's talking to the anesthesiologist. And then I remember thinking to myself, wow, that guy saying I talk too much? I mean, and then I was under. But it was a successful surgery. Still here, it was 20 years ago. And the other parts of this, I think, that are important are that he told me that I was going to need some follow-up, and that we were going to watch for it. Back then, at least, there weren't sort of urine tests to see if your cancer had come back. You had to get scoped regularly, and that's not a particularly pleasant procedure. And he was old school, and it was a rigid scope, and I don't have to talk about where it went. But I can't say I was looking forward to these regular follow-ups with Dr. McLeod, but in fairness, he did every one of them for 5 years. He followed my cancer and reassured me in the same way for 5 years regularly. And, you know, it's like, I don't like going to the dentist. I certainly don't like going to the urologist but I knew that I was going to be reassured when I left his care, And that was the case throughout. And when it was all said and done, 5 years, I remember he said, well, that's it, 5 years. Like I told you at the beginning, something else is going to have to get you. And, you know, true statement. And then I didn't see him much after that because who I am and who he is. I got sick again, not at all related, years later after something else. And it was bad, and I got better. And I got some visitors when I was at the hospital, also Walter Reed. Now it was the new one. But I had most of them were people I was very close to and cared about me, and people that, you know, were my bosses. He wasn't any of those. But he came and visited me that second go round. And, you know, he said, you know, I'm glad you stayed in the Army. So I think of this guy, you know, we all have reasons to sort of say, I want to be like him as a researcher, as a teacher, as a force, as a leader, you know, but to me, it's, I want to be like him as a doctor. He cared for me and he reassured me at my worst times. And I think we can lose all that when we think how great he is. But down at the bottom was just a very, 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 very good and caring doctor. And I will remember him that way forever, as long as I'm around to remember anyway. So I appreciate you indulging me with letting me tell that story. Thank you.
Thank you. Our next presenter will be Dr. Paul Pasquina.
I'm actually not Paul Pasquina, but I wish I was as good looking as he is. He can't make it, so he sent in some remarks. But before I read his remarks, actually I will take, because they're short. Following a psychiatrist, it just sort of reminded me of the story actually with your father, your husband, your grandfather. I'm a surgical oncologist, so a lot of us work in teams, especially in the OR. In these complicated cases, we provide access, and then they do their, you know, certain surgery. And so Dr. McLeod and I, at the old Walter Reed, had a patient in common, not a VIP or anything like that, just a patient. And we were walking up together at the end of a day towards 68 to round together on the patient. And as we turned the corner, a psychiatrist friend of his happened to be right there. Let's call him Bob. I won't give his name because Dave might know him. And Dr. McLeod goes, "Oh, hey Bob, how are you? Oh, good. How are you guys doing? Oh, fine." And all of a sudden, out of nowhere, your father says, "Bob, you know what the difference between you and me is?" And Bob, the psychiatrist, goes, "No, what?" He says, "When I'm done with the patient, I close the wounds." Sorry, Dave. I hope it's okay. If any of you have ever been to a psychiatrist. All right, so now I will do my Paul Pasquina impression. Unfortunately, Dr. Paul Pasquina, Chair of Physical Medicine and Rehabilitation here at USU, was unable to make this afternoon's ceremony, but wanted to share his condolences to the McLeod family and to all of his close friends and colleagues across the nation. Dr. Pasquina
Good
states,
afternoon.
Oh, wait till, it's the good-looking guy that you had on just a moment ago. I told you I'm not as good-looking as Paul Pasquina. Wait till we get it up. There we go, good. All right, so Paul Pasquina states, quote, "Like so many others, I was a huge fan of Dr. McLeod. As a medical student, resident, and staff member at Walter Reed, I was very fortunate to be able to witness him interact with patients, providers, and staff. It didn't matter if you were a private first class, a four-star general, a senior member of the White House. He treated everyone with dignity, respect, and most of all, caring. He brought a level of expertise to military medicine that was unparalleled and stood as a role model for all of us to be the best at what we do, particularly in academic medicine. Although I didn't become a urologist, his lessons of excellence, hard work, and compassion should be copied by all physicians, no matter what specialty. Moreover, Dr. McLeod cared deeply for military medicine and pushed those around him to make places like Walter Reed a world-class medical facility where the nation could be confident to send its heroes for care. He was never shy about his position and always a huge advocate for all of us. As he once told me, "Paul, just let me know if I can help advocate for any of your programs. You'd be amazed how much attention senior leaders give me when I am examining their prostate." Thank you, Dr. McLeod, for setting the example for all of us, and to his family for sharing Dr. McLeod with us. He will be deeply missed. Paul Pasquino.
Thank you, Dr. Shriver. Our next speaker will be Dr. Howard Heidenberg. I don't see Dr. Heidenberg here. Dr. Isabel Sesterhan.
Sorry, I'm back again, but I forgot something this morning. To get the specimens, can you hear me better? To get the specimens for the CPDR fresh tissues, I would go into the operating room and wait till Dr. McLeod was ready to hand me the prostate. So I went over there, I got the prostate, I brought them to the table to take the biopsies. And I always would look at the prostate all over. Is it fine? Where is something wrong or so? And I had this prostate in the hand and I thought, now, where is the posterior surface of this prostate? So I thought, now, I turned it over again and I tried to find it and finally couldn't find it. So I took the prostate and I went very carefully to the table, to the operating table. And Dr. McLeod was busy down there. And then he looked up and he said, "Is there anything you want to, is there any problem or so?" And I said, "Sir, the posterior prostate is missing." He said, "What are you talking about? I gave you the whole organ." I told him, "No, it's missing." He said, "It's missing." And he cobbled a little bit in himself. And then he started working again. And I just waited there. And then he gave me the posterior prostate. So, and he went on, I went on. So next time I came in, so I went to the operating table. He gave me the prostate and he said, "Is everything there?" And he would do this all the time when he did surgery. And if something was missing, he said, "Show me where it is." And then he would go back into the operating field and find it. He never gave up to give you the best he could do. And this was for me. And he was not angry. And it went so far that he would tell me, "Come here on the table, on the top of the table, you know, at the head of the table. And look here in the field, what is this?" I had no clue. Everything was bloody in there. But he wanted to know, is there anything he could take out to make everything right? He was not ashamed. He was not angry. He just took it in and he said, "This will make me better." And the other story I have forgotten to tell you was this. Every year, there were 2 residents who would graduate, come out of the residency, and he had for them a big dinner. We all went there, everybody who belonged to CPDR, to Walter Reed Urology. We went to those dinners. And what I thought was incredible, he had for these 2 residents, for each one, a special present. And these usually were paintings from the Civil War. And what I thought was so beautiful, he found for each one a scene which would fit to this particular resident. And it was just incredible how much time, what do you call it? He had a lot of feeling for his co-workers. He knew what they did. He knew how he could make them happy. He talked to the parents, to the proud parents, told them how great they were, how well they worked, how much they learned. This, I think, we all should remember. To me, he was always very, very supportive. And I was happy to see that he found his peace.
Thank you, Dr. Sessan. Next presenter is Dr. Robert Dean. Dr. Paquette. Dr. Jamil Malouf.
Good afternoon, and my condolences to the McLeod family. I'm a retired Army colonel who in the mid-90s, as a reservist, came to Walter Reed, assigned to the emergency department. And I first met Colonel McLoud, and I was amazed that he would come down with the residents to see patients in the emergency department. In a civilian setting, I never saw the chiefs do that. As has been mentioned by everybody today in various ways, I also have viewed Colonel McLeod as an inspiring father and son of the United States Medical Corps, who dedicated himself not only to the patients, but also as an advocate for the viability of our capital MTFs in this area and their ability to continue referring patients to our two institutions, then Walter Reed Army Medical Center and Bethesda Naval, and specifically to the urology department and to his prostate center. In 2002, I came on active duty at DeWitt Army Community Hospital and maintained contact with him, and he would call sometimes, and we referred patients. As we celebrate so many things he's done, I want to share with you two things that I personally saw him do, and he really helped us in this area. At one point, Malcolm Grove Medical, DeWitt Army Community Hospital was supposed to become a clinic. But several of us at that time, namely the commander who later became the Surgeon General and the chief nurse who became the chief nurse of the Army, the chief of the OB and surgery department, and myself felt that DeWitt Army Community Hospital should not become a clinic. So we set out to make the case, and my job was to present at Walter Reed and at Bethesda the case as to why we need to maintain a hospital so we can maintain all the referrals to the various departments here. He sat on two of those committees, and when I made the presentations, at least my presentations, it was phenomenal. He just stepped in and said, "You mean to say this? And this is what you need, what you're saying, and this is how it's going to help us." And before I knew it, he was essentially advocating what I was trying to say. And I then took that to other times when I presented using the same words. And I know that in his position, he helped us maintain DeWitt Army Community Hospital and its successors, which is Fort Belvoir Community Hospital. The next time he helped us out was I retired in 2005 and went to Malcolm Grove Medical Center. It was a hospital at the time. And we maintained contact. In 2006, I called him once, or he had called, and I said, "Look, we have no urology starting in June till next September." He said, "Don't worry, I'll come in, I'll take care of it." And, I said, "That's interesting." About 2 weeks later, I got a call from the urology department saying that Colonel McLeod was down there to see patients. So I then contacted the wing commander, General Graham, and the hospital commander. I said, "Look, we have Colonel McLeod here. He's trying to help us out." So he came down and told them exactly what he was going to do and how we were going to refer the follow-ups directly to the urology and to the prostate center and how they're going to facilitate that. And then he came in one morning a week throughout that summer to see patients, which amazed me. And he essentially kept us alive. Otherwise, we'd have lost patients to the civilian hospitals. And then finally, in October of last year, I happened to be at the prostate center for myself, and he and Mrs. McLeod had to be there, and he walked by and he saw me, and we chatted, and then in his usual way, he turned to my provider and said, listen, let me know about his case and if he needs anything. And that was in October. So to me, just to paraphrase, he'll always be a great inspirational well for the United States Medical Corps, a well whose waters I think we require when we need commitment, tenacity, courage to advocate as he always did for providing excellent care and for working as he did tirelessly to keep the MTFs viable, proactive, current, competent, as well as committed to medical and educational research. Thank you for the opportunity to speak.
Our next speaker will be Dr. Joseph Sturmis.
Thanks. Yeah, both Dr. Paquette and Dr. Dean had cases, which is why they missed it. I know nothing would have made Dr. McLeod happier to know that two of his residents were missing his event to do surgery. To that end, the only thing that would have made them happier is if they were missing this to do surgery on a federal holiday or a weekend. That would have really brought him joy, I'm sure. One of the things that came up earlier was Dr. McLeod's profound humanity. I have this very vivid memory of being a junior resident, and geez Louise, sorry. I originally hadn't volunteered to speak because of this problem I have, but I said I'd fill in with those folks missing. So we were doing a case, I was the junior resident, and Take It to the Limit by the Eagles came out of the radio. And he stopped and had his eyes closed, head tilted back, singing along, and like rapping the Bookwalter ring with his long debakey in time with the music. And then he stopped and he saw that I was looking at him after the song was over. And he's like, "It's called Memories, kid." And it just, not everybody gives you a window into who they are, but he always did. So, thanks.
Thank you, Dr. Service. Next presenter will be Ms. Chamsi Brown.
Greeting to you. I had the privilege of working with Dr. McLoud for 14 years. He was my mentor. He was always pushing me to go forward until I became the coordinator of the telerobotic medicine. But he never wanted to use the robot. Every time I talked to him, "Why don't you use the robot for prostate surgery?" He would say, he had a finger that was bent, and he would say, "My finger can do better than any robot that you guys may have." I am from Iran. During the hostage crisis, I was working for Dr. McLoud for 444 days.
every day he would ask me about my family in Iran. Do they need anything? Can we do anything? Do you need anything? It was always about other people. I used to tell him that, why don't you become a general, be commander of the hospital so you can resolve all these problems? He would say, then I cannot operate. I don't care about that. I want to take care of the patient. So his whole life was to take care of people. I have a poem here from Jalaluddin Rumi. He's a 13th century mystic poet from Iran. Some of you may know about him. I'm going to read it in Persian first, and then I'll read you the translation. چه تدبیری ای مسلمانان که من خود را نمیدانم، نه ترسا و یهودیم، نه گبرم، نه مسلمانم، نه شرقیم، نه غربیم، نه بریم، نه بحریم، نه ارکان طبیعیم، نه از افلاک گردانم، نه از خاکم، نه از بادم، نه از آنم، نه از آتش، نه از عرشم، نه از فرشم، نه از کونم، نه از کونم، نه از هندم، نه از چینم، نه از بلغار و سقینم، نه از ملک عراقیم، نه از خاک خراسانم، نه از آدم، نه از حوا، نه از فردوس رضوانم. Translation. I hold to no religion or creed. I'm neither Eastern or Western, Muslim or infidel, Zoroastrian, Christian, Jew, or Gentile. I came from land nor sea. I'm not related to those above or below. Was not born nearby or far away. Do not live either in paradise or on this earth. Claim Dawson not from Adam or Eve or the angels above. I transcend body and soul. My home is beyond place. It is with the beloved in a space beyond space. I embrace all and am part of all. I loved him. He'll be a great loss to military medicine, to the world of medicine. And I don't know what else to say. Thank you for allowing me to do this.
Thank you. Now I'll invite Ms. Lois Landsman.
Dr. McLeod, a strong leader with surgical skills, a man of intelligence, endless humor and wit, who worked tirelessly for his patients as well as any of the staff who needed him. He was able to jump any hurdle in front of us to get our mission accomplished. A man who loved well-maintained gardens, either outside his Ward 56 on Georgia Avenue or outside the hallways one passed at the new facility. He always had a joke to encourage gardeners not to give in to the weeds and to please keep the trees and bushes watered. Dr. McLeod was proud of his family and adored his pets. He was a student of history and various battlefields, which was reflected in the artwork surrounding all of us in his Ward 56, as well as in his home. My salute to our hero, boss, mentor, and his family, and this seems apropos. In Flanders fields, the poppies blow, between the crosses, row on row, that mark our place. And in the sky, the larks still bravely singing, fly. Scarcely heard amid the guns below, we are the dead. Short days ago, we lived, we felt dawn, saw sunset glow, loved and were loved, and now we lie in Flanders fields. Take up our quarrel with the foe. To you from failing hands we throw the torch. Be yours to hold it high. If ye break faith with us who die, we shall not sleep, though poppies grow in Flanders fields. That's the end of my tribute. And then the family asked me to say this on behalf of Myrtle Grosvenor, so here I am again. Okay. Myrtle saying, I'm sorry that it is not possible for Myrtle to deliver her tribute personally because of present medical challenges, so she asked us to present this on her behalf. She's saying, the privilege was mine to work with Dr. David McLeod for the last 16 years plus years of my working career. I was assigned to work with him for 2 weeks at Georgia Avenue. I was ready to quit after the first week, but I got encouragement to try the next week, which I did. During that time, I learned that his bark was much bigger than his bite. The 2 weeks turned out to be over 16 years. His name became a household word, and the question would often be asked, what did Dr. McLeod do today? I came to realize that he was a man with a heart. He would go to any length to help anyone, patient or staff, as long as he felt he could. He was a true advocate. I can say that I was a recipient of his advocacy. Along the way, we became friends and confidants. He got to the place where we could almost read each other's minds. Once he told me that it seemed to him that he had a wife at home and another at work. He learned to read my eyes so well that we got along. If we made appointments on his own, if he made appointments on his own for any Ward 72 patient without my knowledge, he would ask the staff to call me before he returned to the office to let me know because he did not want me to give him the eye. As many of you know, he was a practical joker, almost like a 10-year-old. He loved his little white mouse on the trap. Sometimes if you left your computer on and was away from the desk, you could come back to find cockroaches running over your screen. You did not have to ask who was there. He adored his family, especially David, and the dogs were not excluded. When I finally met his David, I saw why. I told him there was no way he could have said David was not his own. Claudia and Yvette, he loved you too, but it was a man thing. Apart from his family, CPDR was his baby. It was his brainchild, and I think he died with CPDR on his heart. He was always concerned about its relevancy, progress, and longevity. He was proud of its success, the people who worked there, and their contributions. I am glad I had the privilege of working with him. He was a man of principle and stamina. He has left us a legacy to follow.
Thank you. Now, Dr. Shriver will read some remarks from Dr. Norman Rich.
Just getting the photo up. Great. Thank you, John. Tribute from Dr. Norman M. Rich, Professor and Chair Emeritus of the USU Department of Surgery, which actually bears his name. It's the Norman M. Rich Department of Surgery at USU, Chairman Eric Elster. Quote, Dr. Dave McLeod was a colleague and valued friend for nearly 50 years, being one of our most dedicated and productive USU faculty members for more than 40 years. He assigned 2 young Army urologists in succession for 1 year each to help establish urology research at USU. Then a third, Major Judd Mall, came and helped Dr. McLeod establish the Center for Prostate Disease Research in 1992, and the rest is history. While Dave McLeod will be missed, his legacy will carry on. From Norman M. Rich. I'm also going to read a sort of late breaking from Dr. Charles Rice. So Charles Rice is the immediate past president of the Uniformed Services University. We're sitting in Rice Hall, which is named after him, and his portrait hangs behind us about 20 feet in the Hall of Flags. President Rice is watching, could not make it today. Sir, thank you for everything you've done for us in the university. And so he sends these remarks for me to read on his behalf. Quote, what a marvelous tribute to Dave McLeod. I am listening in awe and admiration this morning to all those who recounted his multiple contributions to science, clinical care, and mentorship. His impact on the field of urology and on military medicine will be felt for decades to come. My most vivid recollection of Dave is of either my second or third day as USU president. Dave came into my office and Murray Schwartz, who was the executive assistant for many years, Murray Schwartz, who always had such great respect for him, showed him in immediately. He was there to tell me that I needed to demand that AFIP not be closed as BRAC had directed, but be put under the auspices of the university to protect it from, quote, the barbarians at the gate. His words, not mine. Being brand new president, I asked him, how would I do such a thing? And McLeod said, quote, just call Rumsfeld and tell him it needs to be done. I demurred, but said I would certainly bring his thoughts to the attention of Dr. Winkenwerder, then the Assistant Secretary of Defense for Health Affairs. During the next year, he repeatedly berated me for not getting it done, nicely though. Please pass along my respects to Mrs. McLeod and the rest of the family. Chip Rice. Thank you.
We'll now take a brief break while we configure for the virtual presentations. While we're waiting, we have Dr. Noah Schenkman.
Thank you very much. First of all, my condolences to the entire McLeod family, and thank you for inviting me here. I don't have the supreme confidence of Bennett Stackhouse to toss out my written remarks, so I'm just going to read this. Semper Fi. David McLeod started his military service in the Marine Corps at the close of the Korean War. Though he joined the Army after medical school and became one of the Army's fiercest advocates, it was the Marine Corps motto, Semper Fidelis, always faithful, that guided his career. His faith in me changed the course of my life. I first met him on what was termed a residency interview in 1986. I was just another general medical officer working in a troop clinic in Germany, desperate to return for specialty training. My interview consisted of a half dozen interruptions, some emergency signatures, and some phone calls. By the end of the half hour, I was not even sure he knew my name. Strike one. The following year, I again attempted to return from GMO purgatory with another chaotic visit. The interview was a rerun of the previous fiasco. Same interview, same result. Strike two. With my Germany tour coming to a close, a phone call from Dr. McLeod informed me that although I couldn't be selected for the residency program, I could become a general medical officer in the urology clinic at Walter Reed. He said, as long as I did a good job, did not do anything crazy like run off to Mexico with one of his chief residents, I would be selected for residency 2 years later. Not familiar with his particular sense of humor, the chief resident comment caused me some pause, but the faith he placed in me provided a seminal lesson in developing my own leadership traits. Loyalty extended well beyond his physician team. The greatest lessons I learned from the chief were remaining faithful to your patients, putting their welfare way above your own. Whether it was putting a terminal cancer patient into the hospital for many weeks to gain eligibility for an NCI trial, or fighting hard for a retired sergeant to get extra medical benefits that he deserved, Dr. McLeod stood firmly as a champion of his patients. Although I greatly admired and somewhat feared him during my residency, I got to know him best when I returned as faculty. Morning report at 17:15 every day was the main event. After discussing patient care, he would tell us about his love-hate relationship with his pets or his latest Civil War prints that he was able to find. He had special thrill when he was discussing his family, of whom he was incredibly proud. Morning report was a time when he would unleash the great McLeod wit, telling unrepeatable off-color jokes or opining about current events. He would then grab you and go to Ward 72 in the late afternoon to check on the senator or the general whom he had operated on, knowing full well that the VIP was already discharged, but that there were warm cookies waiting for him on the Ward 72 kitchen. The man was a cookie fiend with few peers. As residents, we called him Chief or Dr. McLeod. When I returned as faculty in 1998, it was tough to break that habit. He insisted I call him David, but I could not make that leap. Even after I myself was appointed Chief of Urology, he was the one true chief. There was simply no alternative. His vision to keep Walter Reed at the forefront of innovation, and I was privileged to see the legendary McLeod horse trading up close when he decided that we needed the first Da Vinci robot in the military. We scheduled meetings with the commanders of Ramsey and the National Capital Medical Command. I presented the facts and figures carefully laid out in mind-numbing PowerPoint, and Dr. McLeod presented the vision. Somehow the command went for that $1.3 million price tag, and we snagged the first robot in the military, the 14th one sold in the entire country. Dr. McLeod and I road tripped to Hackensack, New Jersey, to train on the robot. And even though the Da Vinci proved not to be a good fit for his skills, he was an enthusiastic supporter of the technology that retooled my career. After I left service, I tried several times to speak with the chief about the debt of gratitude I owed him. He had a tremendous sense of humility and could feel it coming and would always change the subject or invite someone else into the conversation. That is my greatest regret. I never got to tell him what he really meant to me. Of the things we lose, some are replaced, some are forgotten, and some will always remain a void in our hearts. Semper Fi, Chief.
Thank you. We now have virtual remarks from Mr. Nick Jacobs.
My name is Nick Jacobs. I'm the former CEO of Winber Medical Center and the Winber Research Institute, now the Chan Sun Chung Institute for Molecular Medicine in Winber, Pennsylvania. Today I'm going to talk to you a little bit about serendipity, karma, or divine intervention. It's your choice, but definitely one of those categories fits into this. In 1999, as the new CEO of a small rural hospital near Johnstown, Pennsylvania, I was invited to have dinner at the home of one of our physicians. I was seated beside United States Congressman Jack Murtha. And during the meal, he said, I was explaining to him about my goals and my ambitions with this little hospital. And he turned to me and he said, Nick, if you could find someone who would work with you from either Bethesda or Walter Reed, maybe I can help you. Now, although I knew he was a U.S. representative and a retired Marine, I had no idea that he oversaw the Appropriations Committee, which funded the Department of Defense. So after that dinner, my board chair and I decided to visit Bethesda Naval Hospital. Now, the liaison officer that we met there was not interested in working with us on research projects, but he explained that very carefully. So a few months later, I decided to go on my own to Walter Reed. Now, it's important for me to interject here that I was neither a veteran nor had I ever been there. So consequently, I had no knowledge about protocols, chain of command, or even who to contact. Now, pre-9/11, things were still pretty wide open for visitors on the Walter Reed campus, so I boldly walked into the ground floor of the hospital. And as I entered the building, the realities of military medicine hit me. The place was packed. Almost immediately after I came into the lobby, I saw a white coat in front of me with the letters MD embroidered at the end of the name. It was Colonel David G. McLeod, MD. Now, considering how many doctors worked in that building and how many would not have even given me the time of day, the next few moments positively changed not only my life, but possibly the lives of thousands and maybe someday millions of people forever. I walked up to Colonel McLeod and I said, hello, doctor. My name is Nick Jacobs, and I'm the president of a small rural hospital in south central Pennsylvania. Our congressman had recommended that I come to Walter Reed to see if there was anyone here who might be interested in working with us. Dr. McLeod replied, what's your congressman's name? And I said, John P. Murtha. He looked at me almost in disbelief and he said, follow me, son. I was a lot younger then. Little did I know that simply saying John Murtha's name would get that type of reaction from the first doctor that I ran into at Walter Reed. Of course, I also did not know this amazing Vietnam War veteran, attorney, researcher, and physician had founded the Center for Prostate Disease Research at the Uniformed Services University of the Health Sciences. And there was also no way for me to have known that he understood exactly what to do with both me and with Congressman Murtha. But most importantly, I didn't realize that he would go on to guide another young physician, Craig Shriver, to assist him in forming the Clinical Breast Care Project, a congressional initiative which would collect over 100,000 plus breast tissue samples, which were used by the National Cancer Institute to map the human breast cancer genome. It was about a year later when I first met Dr. Shriver. He came to formally ask me what I wanted to do with the $7.5 million grant that our hospital was about to receive for the study of breast cancer. Now, having been a candidate for a CEO position at a research hospital 7 years earlier, where I had seen my very first genetic laboratory, I looked at him and said, I want our hospital to partner with Walter Reed to become the Genetic Breast Cancer Research Center for the Department of Defense. Let me tell you, I don't know where those words came from either. He looked very thoughtfully at me and said, as long as we're researching genetics, there's a new science called proteomics that we should study too. My reply was yes, we should. I don't really know what either one of them do, so you be the doctor and the researcher and I'll be the administrator. It was Colonel McLeod then who helped Dr. Shriver operationalize the Clinical Breast Care Project. And so I'm here to say, thank you, Colonel David McLeod, because you continue to make lives better every single day. Thanks.
Thank you. And our next virtual presentation will be coming from Dr. Gabriel Haas.
Good afternoon. My name is Gabriel Haas. and I am Clinical Professor of Urology at Loyola University School of Medicine and Medical Director for Astellas Pharma Global Development. I have known David for over 30 years. I first met him when I was a fellow at the National Cancer Institute in the surgery branch, and David gave a grand rounds presentation. At the end of the meeting, he invited the fellows to come and visit him what was then Walter Reed Hospital. A few weeks later, I took him up on his offer, and I spent an entire afternoon touring the hospital, listening to presentations, seeing patients, and watching him operate. It was a wonderful experience. For the ensuing 30 years, we have kept in touch at national meetings, AUA, committees, and various functions. It has always been a pleasure to spend time with David. The amount of knowledge he partaken has been outstanding. But what I cherish most about my interactions with David was something that we did very recently when he was invited to become a legend of the Canadian Journal of Urology International. This is an honor which is bestowed upon those leaders of our profession who have contributed most to research, patient care, and the development of the field. When initially invited, David was quite hesitant to accept this honor, but we managed to talk him into. My role was to guide him through the process of an article. This was the most enjoyable experiences that I have ever had with any of the great legends in urology, and also the most difficult one. Why was that? It was because we had a page limitation of approximately 2,000 to 2,500 words, and David's life experiences could not possibly fit into such brackets. We spent countless hours with the help of Albert Doby as well, working with David to hone down his many, many colorful experiences. He had hundreds of stories from his childhood on, events that became instrumental later, something that we did very recently when he was invited to become a legend of the Canadian Journal of Urology International. This is an honor which is bestowed upon those leaders of our profession who have contributed most to research, patient care, and the development of the field. When initially invited, David was quite hesitant to accept this honor, but we managed to talk him into. My role was to guide him through the process of an article. This was the most enjoyable experiences that I have ever had with any of the great legends in urology, and also the most difficult one. Why was that? It was because we had a page limitation of approximately 2,000 to 2,500 words, and David's life experiences could not possibly fit into such brackets. We spent countless hours with the help of Albert Doby as well, working with David to hone down his many, many colorful experiences. He had hundreds of stories from his childhood on, events that became instrumental later on in him joining the army, his military experience in Vietnam, how he started the urology division at Walter Reed, and consequently the prostate cancer, his prostate cancer activities. There were hundreds and hundreds of anecdotes that he cherished reliving and retelling, interactions with congressmen, senators, politicians in Washington, and very ordinary everyday people that were memories. It seemed that each time when we tried to fit one of these stories in, it was such a pity that we had to narrow it down to only a few. His enjoyment, his obvious relish in telling this, reliving these episodes, became a very memorable event for me that I will never forget. David lived a wonderful life. It was an eventful, careerful activity. He rose to the pinnacle of his profession, and he cherished every moment of it. Rest in peace, David McLoud. Thank you very much.
Thank you, Dr. Haas. Our next recorded remarks are from Dr. Sahelnik.
Good afternoon. After 25 years, I feel that I need to introduce myself. My name is Steve Sahelnik. I knew and worked with David McLoud for 18 years from 1977 to 1995. When I started my internship, my clear desire was to be a cardiothoracic surgeon. Thank goodness I started off cycle in January and rotated through urology prior to applying for residencies. I clearly remember a Friday afternoon as an intern at pre-op conference on Ward 2021 in the old hospital. I guess that's 2 generations of old hospital ago. A patient had an ileal conduit leak and needed to go back to the OR. Dr. Stutzman, who was chief at the time, asked Dave if he was going to wrap the anastomosis with Amentum. Dave replied, that and possibly Dura also. Right then and there, I decided I wanted to apply for urology residency. Dave eventually became my best friend while I was at Walter Reed. Claudia was my big sister. He even was best man at my wedding. By working closely with him for 18 years, I can attest not only to his personality, but also his character. He was omnipresent, not only during daytime hours, but also phone calls every night. His home phone number is still ingrained in my memory. I believe this was him inventing remote working before the internet, PCs, or Zoom. Since this get-together has to be a virtual event and pre-recorded, I assume that numerous people have already commented on his unique personality. Weekend rounds were made not only on patients, but also on the hospital itself, picking up loose objects and delivering those to the commanding general's desk, writing an incident report if we couldn't carry the defective object. The incident report was necessary because every morning the commanding general had to see any reports from the previous evening. Of course, everyone knew him as an institutional person. For example, he told everyone that the lithotripter was going to be placed in room 29. His rationale was that all the administration would be rotated out, and we were the only ones left that were here when that decision had been made. We were the institutional memory. But I would also like to speak to his character, one of loyalty, dedication, and compassion. He was so very proud of everyone that he recruited, trained, and supported, the physician residents, support staff, and also CPDR personnel. I think that we can all attest to what he's given each one of us, not only the physicians, but the residency program itself. There are a number of us that remember coming in every weekend and filling out data sheets for ECOG and other multi-institutional groups before we had the budgets for protocol nurses, data managers, and research assistants. I also think that his greatest attribute was his compassion and empathy, not only for his private patients, but for every patient seen by the clinic. I believe he truly cared for each and every patient and always advised them on what he felt was best for them. I believe that we all are better people because of his caring and actions and having known him. Thank you very much for the chance to speak.
Thank you, Dr. Sahelnik. Our next virtual presentation will be from Dr. Leonard Gamella.
Hi, I'm Dr. Leonard Gamella, Chairman of the Department of Urology at Thomas Jefferson University, and I'd like to say a few words about the great Dr. Dave McLoud. I got to know Dave professionally over the years, but much more importantly, as the chairman of the External Scientific Advisory Board for the CPDR from 1999 until 2017. I had the opportunity to get very up close and personal with Dr. McLeod, as well as Dr. Mal and others at the CPDR, learning really the great work that was done by all the team members there. But certainly, Dr. McLeod was a luminary. He was the influencer. He was the motivator. He always kept everything on track, and his military background made sure that everything always worked at maximum efficiency. Dave really never slowed down that much, even after he sort of, quote, retired. About 2 weeks before Christmas, Dave and I had a conversation about RTOG trials and NRG trials and how these could be put into action at the new Walter Reed National Military Medical Center. So he was out there every day working on behalf of all of the members of the armed forces and all of the men in the world who benefited from the amazing research from the CPDR, the Center for Prostate Disease Research, that Dave was influential in starting. A lot of work done behind the scenes that people, I'm sure, are aware of, with many senators, congressmen, and many other important leaders around the United States who Dave had close interpersonal relationships with, and also allowed his very dynamic style and his commitment to the mission contribute further to his successes in leading not only the Department of Urology at Walter Reed, but certainly in the Center for Prostate Disease Research and Treatment. So I hope I can just show one of my favorite pictures. This is one of our scientific advisory board meetings at the CPDR headquarters, and you can see Shiv Srivastava here, as well as, of course, Dr. Dave McLeod. And I really admire and can't tell you how much I appreciated my time working with other luminaries on the external scientific advisory board, such as Isabel Sesterhan, Bill Dayhut, Oliver Sortor, and many others over the years. We learned a tremendous amount, and Dr. Doby and all the others, Dr. Petrovic's, and certainly Judd Mal's contributions, and many, many others, too numerous to mention, really made such a great team and made some very important discoveries through the Center for Prostate Disease Research. So again, it was a privilege to know Dr. McLeod, and it was really beyond that. It was inspiring to know him and to understand his commitment to excellence across all areas. And again, David, will miss you, but I think your legacy will certainly live on. So again, thank you very much for this opportunity to participate in this memorial honoring the life and times of Dr. Colonel David McLeod. So again, thank you very much, and best wishes to everyone who is participating in the program today.
Dr. Gamella, thank you. Our next remarks will be from Dr. John Berry.
At the AUA meeting in 2009, I presented David G. McLeod with a Distinguished Contribution Award. This meant that the greater urologic community had recognized his contributions to the SMS and Walter Reed. By receiving this award, he joined the ranks that included Alan Ween, Alan Parton, Ralph Clayman, Stuart Howards, Marston Linehan, and Carl Olson, just to name a few of the previous recipients of this award. To me, the annual presentations at the Kimbrough that included the prostate registry that he had set up demonstrated a great principle that healthcare outcomes among ethnic groups vanish with equal access to quality healthcare. Thank you, Dave McLeod.
Thank you, Dr. Berry. Our next remarks are from Dr. Mina Augustus.
Hello, everyone. I am Mina Augustus, founder, CEO, and the Chief Scientific Officer for the Shreyas Group of medical device companies in Gaithersburg, Maryland. It's a real honor and a privilege to pay tribute to the life of retired Colonel Dr. David McLoud when I spent some years at the CPDR and the Walter Reed Army Medical Center and the Uniformed Services University with the Henry M. Jackson Foundation. It was in the late 90s as a visiting scientist at HGS, and I had mapped the prostate cancer gene to its chromosomal location, that we combined the pioneering efforts of molecular cytogenetics to understand the pathobiology of prostate cancer. Working with Dr. Jadmaul, Shiv Srivastava, Dr. Mustofi, and Dr. Sestahan under the tutelage of Dr. McLoud was an honor and a privilege, walking down the hallowed walls of the CPDR and the USIS and the Walter Reed Army Medical Center in Washington, D.C. It was very, very inspiring to have Dr. McLoud put the groundwork for having the clinical pathology of prostate cancer really impact the lives of patients that they were treating, not only at the center but at the multiple CPDR centers across the United States. And for me, that was something that I had never thought possible or even would happen. And that laid the foundation for me to be able to make the technological advances and start looking at ways we could manage the disease that like cancer, looking and having an understanding of the molecular pathology. I really feel indebted to all the mentors that I've had in this elite institution led by Dr. McLoud, and his life reminds me of the psalm of life. Lives of great men all remind us that we can make our lives sublime, and departing, leave behind us footprints on the sands of time. I know that he has left an impact on several students and his fellow surgeons and his fellow military personnel, and I'm sure he will go down in history and be remembered for the loving, kind, and inspirational person that he was. Thank you, Dr. McLoud, for all that you have done for mankind.
Thank you. We now have prepared remarks by Lieutenant Colonel Cheryl Clements.
Good afternoon. I'm the guy frequently referred to as Cheryl, and it's not a she, it's a he. And among the folks that have worked with Dr. McLoud over the years, I was the voice on the answering machine for years and years. This represents a very difficult time for me, so I hope you will be forbearing of this. Dr. McLoud was my best friend almost 50 years ago. Best friend, this is a tough assignment for me. So this actually began with my wife taking our son to Dr. McLoud and coming home and saying not only did he strike her as being a good doctor, he was personable and wanted to continue on with the care program for our son, which was completed. And I think towards one of the last appointments, Dr. McLoud said to my wife, why don't we, the four of us, get together for dinner? And that's what we did. What a wonderful thing with David and Claudia and my wife, Judy, and I. 50 years. Wow. We'd started going to dinner and doing the social things, brunch. We went to brunch at Fort Myer and all around the town. We were quite the socialites. And one of those occasions, Dr. McLoud said to me, hey, the Marine Corps ball's coming up at Fort Belvoir. Why don't I come pick you and Judy up with Claudia? We'll go to the Marine Corps ball and we'll have quite a fun time. So that sounded wonderful. I'd never been to a Marine Corps ball. So we made plans, and the evening got there, and I'm all dressed in my fancy blues, and my wife in her fancy gown. And my wife said to me, "Where are your ribbons?" And I said, "Well, you know, he's a doctor. He probably doesn't have a lot of ribbons. And so I don't want to do anything that would show him up." So she said, "Okay, well, I guess." And so Dr. McLeod showed up with his combat medic badge and his parachutist badge and his Vietnam badge, parachutist badge, and all these awards. So I decided at that point in time, I would go back and I'd wear my decorations. So we came up on a level of parity for that event. I thought it was kind of an interesting thing. I was worried about embarrassing him, and he embarrassed me. Not the first, and nor was it the last. So over the years, our families became very close. We had just wonderful times. Their son, David, slept with my daughter. Of course, they were maybe 5 or 6 at the time. No harm, no foul, right? And we enjoyed being around Yvette. I actually took Yvette to college because the McLeods were away on something. So I delivered her for her first college when that began. Things went on for over the years, and eventually David and Claudia decided they were going to buy a larger house. And so David wanted me to come over and visit with the realtor when he laid out, you know, what they might be interested in. So I was there. Realtor went through his surprisingly very conservative approach. And Dr. McLeod said, "I was thinking of something with a pool." Oh, the realtor got all excited. Boy, that was fine for him. And eventually they wound up buying their home and on Ellsworth, and it was a wonderful time. It did have a pool. But an interesting thing, they got rid of the pool. You ever know anybody that has a pool taken out? But they did. I always thought that was an interesting thing. I would have rather cried than given up my pool if I had one. Time passes, and Dr. McLeod decides he's going to go to law school. And he says to me, "I think you should go with me." He said, "I know you were going to be a lawyer." And I said, "No, well, you know, I've just got my second master's. I'm very uncomfortable telling Judy that I'm going to start going back to school again." He says, "Well, I'm going to do it." And he did. Obviously, he did it in spades. And the interesting thing about it, probably the hardest bar in the United States to pass is the DC bar. And of course, that's where Dr. McLeod had to go get his bar. And he passed, and life went on. Now he was an MD, JD. Pretty cool. Several years later after that, Claudia and I decided we were going to buy David a computer. Now, remember the time frame here. This is in the late 80s, early 90s. Computers just weren't something that you had around. So we got a computer, and then we had to get Errol's to have the internet connection. Of course, they're long since gone. And then somebody had to teach David how to use the computer. He was way before his time. Now, I know all of you are very sensitive to Dr. McLeod's patience of Job. Not. He was an interesting student, as I taught him on his computer and technical support over the years. And that technical support didn't end until long after we moved down to be closer to our kids down on the Gulf Coast, when I finally stuck son David with the responsibility for technical support. Distance finally ate me up. One thing the McLeods and the Clements did a lot of is went sightseeing. We had our day trips and our journeys and so on, and we'd go up to the Shenandoah. My wife was from up that area, and McLeods loved to go up there. And there was a a back road into where we were going at Basie. Basie spelled like somebody don't know how to spell, B-A-Y-S-E. And on that back road was a sign that you would see. It said, Jerome, 2 miles. Nothing else on that road. And then you'd get through Jerome, you never knew it, and then you'd see a sign that was saying, now leaving Jerome. It was always a mystery. Where was Jerome? So we were there one night. It was pitch black, middle of summer, late. Everybody got off from work late. And I had to make an urgent stop, the famous call of nature. I'm sure urologists are familiar with that. And I got out of the car on this lonely back road, nobody around, and all I could see for acres and acres and acres were fireflies. It was the most amazing sight. I've never seen anything like it. And of course, we stood there and regaled at such a beautiful view of nature. So those are a few things that I thought about. And in my preparation for this, I've got a little prose. I can't comment other than to say that I believe from all records and reports, Dr. McLeod was a fine doctor. I know he was a hell of a friend. So the issue for me comes down to this bit of prose. I'm going to share it with you. Our names and our places all forgotten. The brief race of time, well, and patiently run. So let us move away peacefully, silently, only to be remembered by what we have done. Thank you for letting me share that with you.
Thank you, Colonel Clements. Now have Dr. Shriver approach the podium for remarks.
There will be available a recording of the entire day's events on the university's YouTube channel. It will stay up there. So anybody here or in the virtual world who would care to look at it upcoming, it will be available. I want to thank, first of all, the McLeod family. Dave, we've spent many hours on the phone and meetings and Google Meet over the last 3 months. Had a very difficult time for you and the family, asking a lot of difficult questions and sort of coming up with this. I thank you for your willingness to let us do this, and the family and Claudia, and to honor him. I think I can speak on behalf of everybody when I say it's really been therapeutic in a way for us. But we've all been able to hear further the magnificence of this man who we were blessed to have in our lives. I want to thank President Thomas of USU for supporting this. In this era of the pandemic, it takes courage of a certain type to allow something like this to occur. And this is the most people I've seen in a room, without, since a year. I want to thank Chairman and soon to be Dean Eric Elster for all of his support of this event, as well as the life of Dr. McLeod that has led to all of this accomplishment. I want to thank all the speakers, everybody who contributed today. Not easy. It's really been marvelous to hear your interactions with this giant, this legend, who shall never of his kind pass this way again. I want to thank all my partners and colleagues who served on the committees to set this up. We again have spent many hours on meetings. It's been a labor of love. We've done it after hours. And we're all very busy, and Judd, I know you're very, very busy down there, to Duke, to really participate in this. And really, this what you saw today was really from the heart of everybody who participated, not just the committee members, but the folks who spoke. I want to thank the audiovisual team, John, and I think Derek I don't know how this all happened. I don't know how it works. I just, somehow we're on Zoom, we're on YouTube, there's pre-recorded videos, there's clicks, I've been, like all of you, attending all these virtual meetings that we now have, and the professionalism that occurred today and the way I can tell you that this was very complicated to put this all together. So thank you, John, you and your team, those who are out there doing the YouTube virtually. Thank you for your support of this and for making it happen. And then finally, Sharon Holland, if you would please stand up and accept a round of applause from everybody. I don't know how you did it. Thank you. I know it's been hours, scores of hours. You pulled it all together as I knew you would. And I want to thank you for everything you did for it. This concludes our event. Thank you, Dr. McLeod, for your life.